morning, everybody. This morning, I'm going to talk about levels of evidence, critical appraisal, and evidence-based infection prevention. And a lot of people find that evidence-based practice is rather a daunting subject, but that's because a lot of people get overwhelmed by it. And I think it can be a very entertaining topic. So this morning, I'm going to provide entertainment. I'm going to explain what evidence-based practice is. I'm going to introduce the hierarchy of evidence, talk a little bit about what critical appraisal is, and then present the main types of quantitative study designs. The reason I'm going to focus on quantitative study designs is because I think that they are more difficult to read about for yourself if you feel the need, and because most people have had some kind of introduction to evidence-based practice in their pre-registration programs, but people tend in those programs to focus very much on qualitative research anyway. So I think it's better to focus on the things that are harder for you to look up yourself. I think you get better value for money that way. And what we're going to do is apply the principles of evidence-based practice to infection prevention. And there you may be rather surprised by what we say. Now, when we've had this lecture in the past, people have said, now this is all very interesting, but why do we need to understand all about evidence-based practice? How can we use the information? And I think that that's a very sensible thing to have asked. And so now I always put it at the beginning of this lecture, because there's no doubt about it. This morning, we're going to be working hard. And to really get this lecture, you will need to look at it again. So nurses are really considered to be the custodians of infection prevention, and that's enshrined in policy in the UK and in many other countries. And policy and practice are supposed to be evidence-based. That's medicine, nursing, everything these days. But the evidence base that underpins infection prevention and control is very shaky. It is very shaky for a lot of nursing, and in fact, for a great deal of medicine, although people don't really like to admit it. But for infection prevention, it is very shaky indeed. And most of the evidence that we have in guidelines for infection prevention comes from expert opinion, which is considered to be low quality rather than from high quality research, which traditionally has been considered trials. So we have to resort to evidence from weaker study design, and we have to defer to what expert opinion is. So we rely an awful lot on common sense in infection prevention. And later on, I'm going to present to you the parachute study at the end of the morning to emphasize the point. So it's important to know about the hierarchy of evidence to support policy and practice, and to be able to support the decisions that we make. Often in areas of infection prevention, we need guidance very quickly. There's very little evidence available, and we have to evaluate it very quickly with very little to go on. In COVID pandemic, people had to make decisions extremely quickly. The guidance that we had in the UK was based mainly on what we thought exposure to influenza would be, rather than a rhinovirus or a coronavirus, which COVID-19 is, and the country was unprepared. Recently, I gave evidence as an expert witness to the COVID inquiry in the UK, which a lot of people is moving slowly, but a lot of people have given evidence to it. And I spoke about guideline development and the evidence that underpinned the decisions that were made. And in the future, the guidelines that we have will have to be an awful lot better than the ones that we had to cope with this time round, largely because I think a lot of people didn't understand evidence-based practice as applied to infection prevention, and they didn't know what to do because of that. So what we have to be able to do is we have to be able to critique research to see whether it's worth applying, and we have to be able to differentiate between weak research and strong research. And I hope this morning that this will give you some insight into ability to do that. So what is evidence-based practice? Evidence-based practice is really all about finding and using the best evidence available to make clinical decisions. And the idea isn't new. The concept of evidence-based practice originated from the work of David Sackett in the 1970s. David Sackett worked in the US, in Salt Lake City. I think he's still alive, but he's very elderly now. Originally, evidence-based practice applied to epidemiology, but it's since been adopted by medicine as a whole and by other disciplines. And the cornerstone of evidence-based practice is using a hierarchical system to classify different types of evidence. And that hierarchy is called levels of evidence. Sometimes it's called the evidence pyramid. The higher up the hierarchy the piece of research is, the more robust the evidence is considered to be. And the goal is to use the best evidence possible to underpin practice, taking into consideration the needs of the individual patient. So the evidence-based practice gave rise to the evidence-based practice movement, and it arose from the work of Archie Cochrane, which dates from the 1960s. Archie Cochrane comes from the UK, and he spent quite a lot of his working life in Cardiff. So when I used to give these lectures in Cardiff, I used to give them in the building called the Cochrane Building, which is named after him. But there I used to teach the medical students, because in Cardiff they wanted me to teach the new doctors rather than the nurses. I never found out why, but I just obliged, and I taught the doctors there. So evidence-based practice was encouraged to conceive, to encourage the uptake of healthcare interventions that are effective. And it was intended to replace rituals and custom and practice. Because if practice is outmoded, if it depends on things that really we don't need to do, that wastes time and it wastes money as well. People were worried about money in the 1970s, but they're worried about it 50 times more, 100 times more now in the cashed-up world of healthcare that we're moving in now. And if you waste money, if you do things, you can do very dangerous things to patients, as well as just wasteful money-wasting things if you don't know what you're doing. When I first started nursing, of course, I'd been to university first. I was a graduate in biological sciences, and I thought I knew everything. I arrived on my first ward, and I used to see all sorts of things there that used to puzzle me. One of the things that the nurses used to do was that they used to use the piped oxygen in the wall, and they used to blow it across people's open wounds. And I used to say, well, why do we do that? And the nurses used to say, well, because it's to dry the wounds out nicely, because wounds heal nicely if they're dry. And I said, no. Wound healing is a physiological process. Physiological processes work best in an environment that is moist, not flowing with fluid, but one that is moist. In a very dry environment, cells are not going to be mobile and healing isn't going to take place. But they would look at me as if I didn't know what I was talking about. So I shut up a little bit. But then I went on to my second ward, and that was really where I met my Armageddon, because there they had, my second ward was an orthopedic ward, and the patients there were in traction, and they had steel pins, usually going through the bone to support their limb, usually their leg, upright and keep it immobile while it healed. And every few days we would do the dressing around the pin site wound, and I worked out that the pin must be going through bone, which of course is living tissue. A lot of people don't realize it is, but it's living tissue. Bone is replacing itself all of the time. And when we dressed the wounds, we always cleaned them, we always put this solution around them called lead lotion. And I wondered why we were doing this. So I said to the clinical teacher, why are we using lead lotion? Does it contain lead really? And she said, I don't know. So I asked the ward sister, I said, well, what's this stuff called lead lotion? Why are we using that? And she said, well, we always put it on the wounds. And I said, yes, but does it contain lead? And she said, I don't know. So I said, well, lead is poisonous. You shouldn't really be putting it on skin because it's really quite badly poisonous. Does it really contain lead? And I persisted, I wouldn't shut up. So in the end, the ward sister inquired of the pharmacy, which issued the ward with the solution. And the pharmacy got back to her and said, well, yes, the lead lotion does contain lead. We noticed that you used a lot of it on the ward, but we didn't know what you were using it for. The lead lotion was locked up. People didn't talk about it anymore. It wasn't put on the patients anymore. And when I was on the ward, I found that people didn't talk to me very much anymore either. And not very much was said, but when it came to the end of the ward, I got a terrible ward report. And it said things like, well, Nurse Gould might one day be a leader in nursing. She might lead nursing education, but she'll never be a bedside nurse. So I went home and cried. I wasn't very happy, but I suppose I learned an important lesson there, which is you've got to be diplomatic in this world if you want to get anywhere, and if you want to change practice, and if you want to be a leader. And I learned that lesson with a great deal of difficulty from an early stage in my nursing career. But I suppose at the outset, I was interested in evidence-based practice, which was in its very early stages in those days. In fact, I didn't know what it was. I didn't know that it existed. It was in its infancy, but I like to know why I was doing things. And I identified very early on that doing something to patients that you don't know why you're doing it can be dangerous. So evidence-based practice is intended to improve patient care, to avoid wasting time and money and doing things that are dangerous. And that resulted in the Cochrane organisation, of which you may have heard, and the Cochrane Systematic Reviews. And you probably not be surprised to realise that I belong to the Cochrane collaboration. And I do work for them, and I'm involved in doing some work for them now. So Cochrane synthesises and evaluates evidence that underpins healthcare interventions. And there are different levels of evidence. Right at the top of the hierarchy of evidence are the meta-analysis and systematic reviews of trials, which is considered to be the strongest evidence. And next is our individual randomized controlled trials. So meta-analysis and systematic reviews depend on the evidence of lots of randomized controlled trials individually, all brought together. Then below that, less robust than that, are different types of trials, designs where there is no randomization. And at the bottom, I've reminded us what a randomized sample is, and we'll talk about that in a minute. Below the quasi-experimental study designs, where you can't have randomization, come other quantitative studies, and we'll talk about those this morning, and then qualitative approaches. It doesn't matter if you've never heard of some of these things. By the end of this morning, you will have heard about them, and you will be able to think about them and to talk about them, especially if you look at this lecture again. But a randomized sample is one where every member of the population has an equal chance of being included in the sample. And randomization is important because it increases what we call the external validity or generalizability of a research study, whether it's a trial or any other kind of study. So, for example, if we do a study in one hospital, we want to know, does it just apply to this hospital or will it apply to hospitals everywhere? Because if it just applies to one hospital, then to apply it in other places isn't very sensible. But if we've done the trial in a robust manner using a random sample, then our work would be generalizable. So I will give you an everyday example of the importance of having a random sample. I live in West London in Barnes, and Barnes is a very affluent area, and it's an unusual area in that it contains more families and young children than anywhere else in Europe. My husband was working, he's been retired now for quite some years, but when he was working, if we were wanting to have anything delivered in the house, like a new washing machine or whatever, where they actually have to bring it in, it would usually be me working from home because I had a job that would allow that, whereas he had to go into the office every day. But on one occasion, there was something I had to go to work to do. And when I came home from work, my husband was entertaining a gentleman. And this gentleman was doing a survey. And the survey was quite obviously funded by a number of companies, and it wanted to find out what people spent their money on. So a lot of the questions are about products that you bought. So this gentleman was very interested in what kind of car you had and how much petrol you used and how much money you spent on schools if you educated your children privately, how much you spent on children's clothes and nappies and all sorts of other family-related things. But we are odd of people who live in Barnes because we don't have any children and we don't have a car. We don't have a television either. We really are very odd people. So we don't spend money on lots of things that the average person in a locality like that does spend their money on. We spend our money on all sorts of terrible things like going out, which is not always perhaps the best thing to do with your money, but certainly we're not typical of where we live. Now that wouldn't matter because in any population, you do get people and things who are odd. But what did matter was that for months afterwards, this person would be hanging around our doorway when I came home from work. Now, what he must have had was a quota in which he was supposed to include so many different people of different men and women of different ages. And it was obviously very difficult for him to get a population of men of working age in his sample. So he kept coming back to our house, hoping my husband would be in. My husband was never in, but I was. So I would always take pity on him and ask him in and give him a cup of tea and answer the questions, which were always the same sort of questions, but for different companies. But time and time and time again, the information that he got was from the same household, and it was from a very atypical household. So that would have introduced a great deal of bias into the sample that we had. Another example of bias that can be brought about by not choosing your sample very well occurred to me in the last few years. I worked with a colleague who was a director of infection prevention in one of the big London trusts, and a company contacted the trust and wanted to introduce a piece of equipment that was to do with hand hygiene, an expensive piece of equipment that had to be installed on a ward. And so we did the work with them, and the project was a success. And afterwards, the company hoped that they would be able to introduce their product into other trusts. So they went to a number of other trusts, but they didn't get very much success there. And eventually they tried to implement the product in a private hospital. And the private hospital wasn't very interested in the product either and wasn't very helpful. And eventually the company abandoned the UK altogether and went to Germany. But they decided that even in Germany, people were not very helpful in installing the product and evaluating it. And afterwards, the person from the company in Stockholm said to me, you know, Dinah, when we were installing the product in St. So-and-so's hospital, I didn't realize what a good hospital it was. And I didn't realize how good Janet was. She was the ward sister. I didn't realize how helpful she was. I didn't realize how good she was to me. And I didn't realize how good Neil was to me and how good you were. I didn't realize that was what was so special, and that was what made the product very acceptable. So you can see that the sample was not very well chosen. It applied to a special hospital, and the information wasn't applicable everywhere. So you can see the everyday importance of being able to generalize. Thanks. So this slide shows you the evidence pyramid in a diagrammatic form. If you want to see this diagram a bit differently, you can look on the web, you can put evidence-based pyramid into Google and it will bring it up for you. But you can see there's systematic reviews at the top, then randomized controlled trials, then other sorts of trials at the bottom, right down to expert opinion. So there are key points that we need to make. The hierarchy of evidence applies best to quantitative research methodologies, the ones that contain numbers. And the Cochrane organisation focuses best on evaluating randomised controlled trials, although Cochrane has now developed protocols for looking at other sorts of research as well. But it's important to remember that different disciplines do value evidence differently. Doctors, medics particularly like randomized controlled trials, whereas nurses tend to favour other different approaches at least as much. And the research approach has to be practical and feasible. It isn't always possible to do something that's very rigorous. In infection prevention, it often isn't. It might not be possible to apply a research approach that's high up the hierarchy, where it might not be appropriate. You don't need a trial to explore how people feel about COVID-19 vaccinations. They may be in favour of it, or they may think, well, no, I don't want any more injections. I'm fed up of it. I'll take my chances. COVID isn't it's not killing people anymore anyway. It's getting to be a milder infection as antigenic drift occurs. I'm not going to have a vaccination, but you don't need a trial to find out what people think about COVID-19 vaccinations. It's much easier and much cheaper to ask them. A trial won't tell you people's feelings. So let's revise quantitative and qualitative research, which I'm sure you must have covered at some stage a long time ago. Quantitative research always analyses numerical data, and that's where the quant comes in the title of it. So quantitative research is the approach that's used by scientists to test a theory. So a theory would be that a wound dressing promoting a moist environment encourages healing. The theory that we have in science usually comes from basic science, usually a laboratory study or a simulation study, particularly in educational research, or a clinical observation, perhaps related to wound healing. Infection prevention traditionally derives from science. We did that whole great whack of microbiology earlier on in the course. Epidemiology about the patterns of diseases in communities is very much a science. So traditionally, infection prevention is quantitative. Qualitative research, though, analyses non-numerical data. Qualitative research doesn't deal with numbers. It sets out to understand concepts and opinions and experiences. So it explores people's opinions about antibiotics, vaccines, and all sorts of other things. So infection prevention strategies depend an awful lot on people adhering to guidelines. And you can't just say to people, well, here's the guideline, get on and implement it in your ward, in your hospital. We have to understand people's opinions. We have to see whether they like the guideline, whether they believe in it. And we need that in order to implement the intervention of whatever we're going to do to promote adherence to it. So qualitative research has its place in infection prevention as part of mixed method study designs, and sometimes we just do qualitative research on its own. By background, I'm a scientist, and so people always think, well, I must be deep dived in quantitative designs. Well, I am, but I do qualitative research too. I do think that it depends very much on the problem that you're trying to address, and the research design that you use should be based on that, and not because you're a dyed-in-the-wool quantitative or qualitative person. So let's talk about intervention and observational studies, which is another important distinction that you need to get your head around. Intervention studies are ones where we do an experiment to test a theory. An intervention is where you do something to a group of people or a group of things. So you manipulate them, you introduce a change, and you have test groups that get the intervention and control groups that don't. And intervention studies always involve quantitative methods because there's got to be measurement in there. Observational studies are the kinds of studies that we do when we want to do quantitative research, but when intervention isn't possible. And we'll talk about that in a minute. So intervention studies, by tradition, come higher up the hierarchy than observational studies. But we have to think about that very carefully. Black was an epidemiologist who worked at the London School of Hygiene and Tropical Medicine, and Nick Black was a very clever man. And on one occasion, he wrote quite an interesting article, a very clever article, in the BMJ, and he pointed out that a well-conducted observational study is probably worth more than a badly conducted trial. If you can't do a trial very well, then don't bother with doing a trial. Do something else instead, but do it as well as you possibly can. And that is why we need to be able to critically appraise research. A lot of people get critical appraisal wrong. They think that critical appraisal is criticizing something and pulling it to pieces. Now, critical appraisal isn't that. Critical appraisal is the method of systematically examining research to assess its trustworthiness, whether we can believe it or not, its value, and its relevance to practice in a particular context. So you may look at a piece of research, and it may be a very fine piece of research, and maybe it's been very well executed, but it applies to care of the elderly. And you work on a neonatal unit, and you can't apply it where you work at all. It doesn't mean to say there's anything wrong with the research, but you just can't use it very well. So the key questions we need to ask ourselves are, what are the study findings? Do we believe them? Are they helpful? And do they help us to support local practice? Are they relevant? There are different critical appraisal tools. There are hundreds available. You can go online and you can locate lots and lots and lots of them. But the critical appraisal skills program, CASP, that you can call up for nothing and use online, is one that is used in many, many universities, including the one that I used to work in most recently, and I think Coventry use it as well. So CASP asks these key questions. What are the findings of the study? Can I believe them? Are they valid and reliable? Are they valid? Do they measure what they're supposed to measure? And would they give you the same result if you did them somewhere else? Can I apply them where I work? Are they relevant? And there's a CASP tool that applies to surveys. There's a CASP tool that applies to different sorts of trials. So you just have to choose the tool that applies to the kind of research that you're looking at. When you submit a paper to a journal, then it goes to referees, a number of referees. They're supposed to look at it, and they're supposed to critically appraise your article for you and tell you whether it's worthy of publication, or whether you've got to improve your paper before it can be published, or whether it's a write-off and it really shouldn't be published at all. And when you send an article to a journal these days, you're relying on people to do a critical appraisal for you very sensibly. About 2 weeks ago, we sent off a paper to a journal that shall be nameless, and yesterday we got the feedback. And I don't think the people who were reading it did a proper critical appraisal upon it at all. They just said they wanted to see the questionnaire that we used. The questionnaire was there, but they didn't even realize that they'd read it. So I can get my article published very easily. It will be published very soon online, but I won't be using that journal again because I don't think they did their critical appraisal very well. So let's look at intervention and experimental studies. Intervention studies and experimental studies always involve manipulation. They test the effectiveness of an intervention, and the intervention is a change or an action or treatment of some kind, and they test it on a selected outcome. And the effects of that manipulation have got to be measurable, and that's where the quantification come in. Now, major studies, big expensive studies that are funded, can combine quantitative and qualitative approaches. The quantitative approach, the numbers, tell us whether the intervention worked, and the interviews explore the experience and tell us why it worked or it didn't work, and how it worked, and what people thought of the intervention, and whether they would be willing to abide by it again. So intervention studies have particular characteristics. The intervention is the change we test to determine whether it achieves its desired outcome. And we can have single interventions or we can have complex ones. A single intervention could be something quite simple, like does taking daily aspirin reduce the risk of heart attack? And you're probably very well aware that aspirin is quite a powerful anticoagulant, and it is widely prescribed to reduce coagulation in people who are at risk of cardiovascular problems. A complex intervention is often described as a bundled intervention. And so an example of that would be there's a package that involves bedside availability of alcohol hand gel, training people to use it and reminding people to use it and giving people feedback. Does all that improve hand hygiene, adherence to hand hygiene protocols? And I'm sure that you're well used to the use of alcohol hand rubs where you work. So randomized controlled trials are an example of an experimental approach. Traditionally, they're regarded as the gold standard evidence in research, and they're designed to test the effectiveness of drugs originally. And that is where the classic double-blind randomized control comes in. And randomized controlled trials from the world of pharmacology have been adapted to test the effectiveness of public health interventions. Infection prevention is really an example of a public health intervention. Infection prevention goes on in hospital as well as in the community, but that doesn't alter the fact that really it's a public health. It's a part of public health because it applies to a lot of people. Now, there are strengths associated with randomized controlled trials, and they allow us to determine whether the intervention is directly responsible for the effect it has on the outcome and conclude that the outcome isn't influenced by something that's going on at the same time that we haven't measured. Observational studies don't allow us to make this assumption so reliably, so they come lower down in the hierarchy. And randomized controlled trials depend on our ability to minimize all possible sources of bias. Bias is a systematic influence of other factors than those that we're measuring that could affect the study outcomes. You don't want to have bias in any kind of research study, but certainly not in something that is being used to test the effectiveness and the safety of drugs. If you have somebody repeatedly collecting information from the same people or the same situation, like the man who came with his survey to my house, then you're getting repeated bias in there, and that means that the research is basically flawed. So the purpose of randomization, making sure that everybody in the population, in the whole group, has an equal chance of being included in the study, helps to eliminate bias and increases the external generalizability, whether our findings can be applied anywhere. So the characteristics of an intervention study is that they're conducted to test a hypothesis. A hypothesis is a statement, and the statement has to be clearly expressed. So if we want to take our example of aspirin, taking daily aspirin reduces the risk of heart attacks. So a hypothesis has to be quite precisely stated. You can't have a sloppy hypothesis because the research would be sloppy. In fact, you wouldn't be allowed to do it because the ethics committee wouldn't let you. So a nice precise hypothesis would be dose of aspirin. You have to work out the dose of the aspirin that you're going to give somebody. You have to define the period of time you're going to give it, the number of heart attacks that are recorded during the time that you collect data, and you have to decide in advance how long you're going to carry on doing your trial. Remember that trials are quite complex to do and they cost a lot of money, so you can't do them indefinitely. They will have to occur over a pre-decided period of years because you have to have a budget of money and you're going to have to apply that budget. The manipulated variable that we test is always against a placebo. A placebo is either usual treatment or no treatment at all. And the association of the variables is determined by statistical testing. And in this lecture this morning, we're not going to cover statistics, whereas if you did a course about research, you would. A double-blind randomized controlled trial is the typical one that we do. And here, a research question would be, does taking X dose of aspirin, whatever dose it is, however many milligrams, every day, reduce the risk of a heart attack in the general population? So there's going to be lots of forward planning there, the daily dose, how long the trial is going to go on for, what information we should give patients about the information and the trial, and if it's taking place in hospital, then we should speak to the staff as well. And if it's taking part in the community, we need to talk to the patient's GPs. And the patients are randomized into two groups, the test and the control group. So how does randomization work? Randomization works the way that everything works these days, very boringly in front of a computer screen. So you get a random number generator, which you can call up for nothing on the computer. You can do it yourself. You can put random number generator in, and it will give you one there where you sit. Every patient gets given a number. The numbering system allocates the patients either to the test or the control group. And you can't predict which group the patient will be allocated to. It occurs entirely by chance. But equal numbers get allocated to each group, but entirely by chance. Randomization means that every patient in that population has an equal chance of getting or not getting the treatment, and that removes the risk of bias. And risk of bias is very important in a trial about aspirin and coagulation and heart attacks, because as you're probably aware, more men than women suffer from heart attacks up until women reach the age of the menopause, because then the risk becomes equal across both sexes. The hormone estrogen, which is produced in a greater amount in women during the reproductive years, is protective against heart attacks. So it would wreck your experiment, it would wreck your trial if you had more women than men in the trial, women of premenopausal age. So what you would do if you wanted to conduct a double-blind RCT is you would randomly allocate people to the test and control groups. The test group would get the aspirin, the control group would get tablets that look exactly like the aspirin, the placebo tablets, and the patients can't tell the difference between them and the real thing, and neither can the people dishing them out or the people analysing the data. The patients are blind to group allocation. That means the patients don't know what group they've been put in. They don't know whether they're really taking aspirin or not, so they can have no preconceived notions about whether they're going to be protected from heart attack or not. And the researchers who give the tablets don't know either. So that's the double blinding bit of it. Both groups are in ignorance. And so that can't influence the outcome. Now that's nice and neat, but what can go wrong? Well, lots of things can go wrong with actually. There's all sorts of bias that we can get in randomized controlled trials, which can reduce their validity and whether we can believe in the findings. First of all, selection bias can occur. Now, selection bias ought to be overcome because everybody in the population is supposed to have an equal chance of being included in the study. Everybody who's eligible to be included in the heart attack trial has an equal chance in the prescribed population of being included. But that doesn't always work because people can refuse to take part in a trial, and they very often do. I always choose this example on purpose, partly because it will be familiar to you, but also because I would never in my wildest dreams take part in an RCT designed to look at the effects of aspirin. I'm one of those people who are not unusual in that I bleed excessively. I don't have a disease like haemophilia. I have some other bleeding disorder that isn't severe, but if I took aspirin, it would be very dangerous. because I would probably get gastric bleeding. I know that, and so I'm never going to take part in a trial to do with aspirin or any other anticoagulant. Then there's another kind of bias that we call performance or confounding bias. People in the test group might get extra attention. They might get more visits, more follow-up visits. They might get more diagnostic tests, and that could improve their outcomes compared to controls. So that's another source of bias. If somebody thought that they were bleeding as a result, they'd very quickly be referred for medical care. If they were actually being given aspirin, you break the code and you find out whether they really were having the aspirin or not. Attrition bias is differences between the test and control groups. People in the groups might withdraw from the trial. They might get fed up with taking part. They might die if it goes on for a long time. So the trial might not work because of people not coming to the end of it. Then there's measurement bias. The data might not be collected in the same way. If we were looking at a hand hygiene product and its effectiveness, it would be very important that hand hygiene was audited in the same way. But if you've had anything to do with hand hygiene audits, you know that not all people doing hand hygiene audit do it in the same way, that a lot depends on the person doing it. So that would be an example of a measurement bias. And contamination bias is another bias. When people in the control group get the intervention by mistake, or they're alerted to it, and they realize that something is going on. And there's a very nice example of that from the very first research study that I ever took part in. Before I became interested in infection prevention, or before I became professionally involved in it, in fact, I was a gynecology ward sister. And the first project I ever did was on a trial looking at recovery from hysterectomy, which was a very widely conducted operation at the time. It was one of the most commonly conducted operations in the country. This was really quite some years ago. Two of us worked on the trial, and one of us gave a counselling intervention to the patients to see if counselling made any difference to their recovery. And the other one of us collected the baseline data from the patients in the ward. And one day I was sitting with my lady, giving her all the information about the study and whether she would like to take part in it, and the other researcher walked down the ward, having counselled the patient about what to expect during recovery, which included, of course, inevitably with an operation like hysterectomy, return to your sex life. And a lady down the ward came across to the lady I was sitting with and nodded at the other research assistant and said, "There she goes. There's the one who tells you all about the KY jelly." So that's having patients in the same ward, and the patients, of course, will talk to one another. They will know what's going on, and contamination between a control group and a test group is very likely to occur. The other research assistant, of course, had no sense of what should we say, a sense of humor at all. And she couldn't understand why I and my patient were falling about laughing. She really couldn't see that there was something to laugh about, but there was always something humorous, even in a subject like research. So let's look at drug trials versus public health in the real world. The aim of a randomized controlled trial is to try and ensure that the test and control groups are exactly the same, and assume that all the other things that are going on that could affect the outcomes of the trial are kept constant. But public health interventions take place in real life. Randomized controlled trials are all right if you're dealing with mice or if you're dealing with test tubes, but people are different. And public health interventions take part in the real world, and the real world changes. We can't hold the real world constant because it's changing all the time. And it's going to change while we're doing the trial. And infection prevention particularly is affected by things going on in the environment. So infection prevention research is particularly hard, particularly challenging to do. And the trials are not always very good, as by the end of the morning, you will learn. And particularly in infection prevention, trials are affected by seasonal trends, secular trends, and cyclical trends. And it's important that you should know what those things are. So seasonal trends are things that occur, things that change with the season. We all know that virus infections are much more common in winter. So is norovirus. Remember winter vomiting from the first lecture that we had. Food poisoning tends to be more common in hot weather. Surgical site infections are more common in hot and humid weather as well, particularly in countries that are hotter than the UK. So the season does in fact affect the rates of infections. and that would affect the outcome of a trial if we were doing one. Cyclical trends are things like public holidays. They can have impact on staffing. You have more staff that deliver the care in ordinary times than you do over a public holiday, and that can have an impact on infection rates. Secular trends are trends that aren't seasonal or cyclical, but they occur anyway. Hospitals might introduce a new policy, there might be a change in a public health intervention, there might be a change in treatment that's introduced, and all of those things can have effects on any kind of research study that you're attempting to do. But seasonal, cyclical, and secular trends have a great big effect on the outcomes of trials, and they're a major source of bias. Oh, we're just fiddling with the slides. So there are different types of randomized controlled trials, and you will read about them, so I'll give you some examples of them as we go through. So a classic randomized controlled trial are the ones where patients are allocated to test and control groups, like the aspirin trial we've just been talking. Some trials are two arms of a trial. Those are the simple trials where you have just one test and one control group. But in some trials, you have more than two arms. For example, you might have one control arm, or you might have more than one test group. For example, you might have people who are exposed to different dosages of a drug to see which one works best. And a lot of public health interventions would have more than one arm. Then there are crossover RCTs, cluster ones, and step-wedged ones. And I'm going to go through each one in turn. This one, for people who like diagrams, is a flow diagram of a classic two-arm RCT. So you get the sample population, the dice there represents the randomization, the chance. Patients are allocated to their group according to chance. Group 1 actually gets the treatment, whatever it is, the aspirin or the antibiotic or whatever, and then we look for the outcome. The outcome is whether they get better or not. And in group 2, they don't get any treatment or they get a placebo, and we look to see if there's any difference between those two groups, usually by doing some kind of statistical test. So that's randomization that applies to individual patients. In a crossover RCT, then we do these to assess the impact of one or more interventions, but in these kind of studies, everybody gets the intervention, whereas in a classic trial, only half of the patients do. But what happens in a crossover RCT is that halfway through the trial, the groups cross over and everybody gets the intervention, but it's the order in which they get the intervention that is randomized. So the advantages of crossover trials is everybody gets the treatment, so that's ethical. It helps people to persuade people to take part. The participants act as their own controls. There is no actual control group. Crossover RCTs are often used in physiotherapy, teaching people exercises, often used in dietetics, giving people different diets. We do use them sometimes in infection prevention, and we'll have an example in a minute. The disadvantage of crossover trials is that we often have to have a washover period that extends the length of the trial. And if we've been given somebody a special drug, then we can't cross over immediately because the effect of the drug needs to wear out of their system. And if we're going to do something to somebody that's irreversible, then we can't have a crossover RCT. If we want to look at the effect of a new guideline or a training session or a new kind of hand wash, if we take it away, it's going to be very difficult. We can't say, well, last week we wanted you to do this, and this week we want you to do something different. People won't really listen to us again. It's making life very difficult. So that means that for many things that we do in infection prevention, a crossover RCT isn't going to work very well. People get interventions at different times as well. And so seasonal and secular trends can still occur, and we can still get confounding. So an example of a crossover RCT in infection control is one that was done by Rupp in Canada a few years ago now. The research question that Rupp came up with was, can alcohol hand rub with education at the same time increase hand hygiene adherence and reduce infection rates? So if we give people alcohol hand rub and we teach them how to use it, will they clean their hands more, and will infections go down? So the intervention was the alcohol hand rub and the teaching, and it was a crossover design. It took over 2 years, and the people on the control wards got the alcohol hand rub first, and the test and the other people didn't. And then after 12 months, there was a crossover, and the first ward that had got the alcohol didn't have it for the next 12 months, and the people who'd been without it in the first place then got it. The sample was 2 critical care units in Canada, and the outcome measures, what they were looking at, the difference, was hand hygiene and infection rates. Introducing the hand rub increased hand hygiene adherence in both groups, in all the wards. It went up in group 1 from 37% to 68%, and in group 2, very similar, 38 to 69%. But infection rates didn't actually go down. There was no reduction in MRSA, which they measured, in vancomycin-resistant enterococci, or C. diff, or in gram-negative infections that you'll remember from all the talking we did about microbiology. And the secret was the kind of alcohol that Rupp introduced. He introduced 62% ethanol. What percentage should he have used? Well, if you look on the bottles available in your clinical areas, you'll find out that the percentage of alcohol in them is at least 70%. But people didn't believe the results of the trial. They said, no, alcohol hand rub does kill bacteria. We know that from laboratory studies. The trial should have worked. People wrote to the journal, they even wrote to newspapers in Canada and said they didn't believe the study findings. And somebody in Vienna, where they did the original work on alcohols and their development in hand hygiene, somebody from Vienna eventually wrote to the journal and said, well, of course the trial didn't work. They didn't use the proper concentration of alcohol. So this is a good illustration of a study that was methodologically actually very sound, but it didn't work because the people who designed it didn't bother to look at the product that they were using. It illustrates how complicated it is to do a trial and how carefully you have to think everything through before you embark on the trial. Cluster randomized controlled trials are trials where the whole organization is randomized to a test or control group. So it's not the individual patient, it's a whole hospital or a whole GP practice. And that overcomes the problem of contamination between test and control groups. If you had individual people who are randomized, maybe individual members of staff in a trial in a hospital, they might meet in public areas on a study day or in the dining room and talk about what was going on in their ward. And you might get contamination that way. But if they're segregated in separated hospitals, then that can't happen. CRCTs are very big, expensive studies. And they are done, but they cost a lot of money. A good-sized trial, a good-sized randomized controlled trial costs between probably £2.5 million these days. You probably knew that research was expensive. Research is very expensive indeed. When I worked at Cardiff, I used to do a lot of work with the trials unit. And there they ran a great many trials and brought in 3/4 of the university income. They did quite a lot of commercially funded trials as well, and that was where a lot of the money came from. But a cluster randomized controlled trial will cost even more. But still, they're flawed, they're not magic. Some organizations are very good organizations, and that influences the outcome, like the ward where we introduced the hand hygiene equipment in St. So-and-so's. We had a very enthusiastic ward sister there, and the equipment was very well received, and the nurses all were very keen to try it out. So that pilot study went extremely well. Then we get good hospitals where staff adhere to guidelines, patients get better more quickly, and randomized controlled trials can't get rid of that source of bias. An example of a cluster randomized controlled trial is this one that was done in Hong Kong in 2011. And the aim there was to look at the effectiveness of the hand hygiene program in long-term care facilities. People live a long time in the West, but in the Far East, they live even longer because their diet is very good. And so the study design, they had 6, it was a cluster randomized controlled trials. They had 6 nursing homes that were randomized to get or not get the alcohol hand rub. And the follow-up period wasn't very long in this study, it was only 7 months. So they measured alcohol uptake and serious infections where the old people would or wouldn't need to go into hospital, things like pneumonia. And in the results, you can see that in the test long-term care facilities, hand hygiene increased and serious infections fell from 33 cases to 31. But in the controls, where they didn't have alcohol hand gel, there was no change in hand hygiene, and the serious infections actually increased. the long-term care facilities weren't all that equal, because there tended to be more infections in the ones in the control groups anyway at the baseline. And there were more severely disabled residents in the control groups purely by chance. The sampling wasn't really all that good. But this is an example of a CRCT in nursing homes. Step wedge CRCTs explore effectiveness and safety of an intervention intended for routine use. It's often used in developing countries, low-income countries, to test the effectiveness of something that we think will work anyway. Vaccines. A big cluster wedge study took place recently in Australia to improve cleaning in hospital wards. So what we do here is we collect baseline data for the whole population. We split the population into units, often hospitals or wards. We randomise the patients in one unit to the control or the test groups, and we do an intervention. We follow people up. And if all goes well, then we repeat the process in the next unit, the next hospital, and then the next hospital, and then the next hospital. And we randomise as we go along, so everybody gets the intervention. The advantages of step wedge cluster randomised controlled trials is, although they're very big studies, what you're doing is you're giving the intervention to different small scale units at any one time. So there are only small samples that you're dealing with at each time. And the switch from test to control groups goes on over a short term. So we don't have, if something goes wrong with the trial, we don't have to cope with all the problems at the same time. And that particularly would be important if you're doing it out in the middle of Africa, a low-income country. The advantage, again, of these studies is that they're ethical, everybody gets the intervention, and it's politically acceptable. A country and the governors of a country will be more willing to take part. The governments would be more likely to participate if everybody signs up, because they all are going to get an intervention that in the end we think is beneficial, such as a vaccine. The disadvantage of these trials is that the timing of the exposure to the intervention is different, because you're doing it to the trial, different units as you go along. So that still doesn't get rid of seasonal and secular trends. So you've still got confounding variables. These studies are very complex and they can be very difficult to analyse. Remember that we talked about infestations and worm infestations when we talked a few weeks ago. Well, here is an example of a step wedge trial that took place in Kenya some years ago. And the research question that they had there are there health and educational benefits of a school-based deworming programme? The incidence of worm infestations is very high in Western Kenya, which by and large is not a very wealthy country. And so the intervention that they had was to give antihelminthic medication, worming tablets, at school, and health education lectures and posters to the children. So they went to 25 schools, which were randomised into 3 groups, and each group got the intervention at a different time. It was the order of the intervention, the order of the worming programme that happened. And the study took place over 12 months. The outcome measures they looked at were school attendance and performance in exams. After the intervention, after 12 months, school attendance was better, but exam performance was not. One of the limitations of this study was that people weren't blinded according to their group allocation. If you're going to give somebody medication that is sufficient to make them pass large numbers of worms, you have to warn them that that's going to happen. Otherwise, they're going to be frightened, and you're going to really scare people. So it wouldn't be considered right to do that or ethical to give them that medication. And there was also a lot of missing data. Despite the fact that school attendance did increase after the intervention, there was still a lot of missing information. If you go to a school right out in a rural area, in the harvest time, people are going to be helping with the harvest. They're not going to be coming to school. A lot of people missed exams. So the data were not very easy to interpret. An example of a step wedge study that was done very recently was one that was reported this year by somebody in Australia called Mitchell. This trial took place in all the wards in one hospital in Australia. Each ward was a cluster. And what Mitchell established was that when people share equipment, like blood pressure equipment, like equipment that's shared a lot between patients, cleaning doesn't occur very well. And they did a systematic review to establish that. So in the intervention that they had they looked at better cleaning of shared equipment. And they got the in-house cleaners in the hospital to agree to put in 3 hours extra worth of cleaning per week. And the cleaners received special training to clean that equipment. There was a substantial reduction in healthcare-associated infection over a year. The cleaners evaluated the training and their extra duties positively, and that was qualitative research. So this was also an example of quantitative and qualitative research combined. And there was an economic evaluation in this study as well, although it was published in a separate paper. This paper was published in the Lancet Infectious Diseases earlier this year. I did the reviewing of that study. 6 people reviewed that study. It was very well reviewed indeed. It's a very good study, and I'm waiting with a great deal of anticipation to see how it's going to change practice in terms of hospital cleaning, not just in Australia, but in other countries as well. It's a very important study. Now, I've been talking here for nearly an hour, so this would be a good time for people to have a break. So let's look at the kind of trials that you can do when you can't have randomization. So sometimes a randomization is impossible. So when we can't randomize for practical or ethical reasons, then we have to match our test and control groups. So we have to try and compare a test group that doesn't get the treatment, that does get the treatment, with a control group that doesn't. And poor matching is a catastrophe because you can't compare things that aren't alike. Apples and pears are completely different. You can't say this is a nice apple and this pear isn't a nice apple because the pear is not an apple. So you get systematic bias in this kind of situation. And so these studies are never going to produce generalizable findings. We don't have all that many very good examples of quasi-experimental trials in the literature because people don't tend to do them very much these days. But one of them was done by Elaine Larson in the States some years ago, and she introduced a hand hygiene campaign on a recovery ward, an anaesthetic ward, in a surgical unit and a neonatal unit. The one unit acted as a control, the other got the hand hygiene campaign, and then she tried to compare the outcomes from both of the units. But, you know, is an anaesthetic recovery ward the same as a neonatal unit? Well, of course it isn't, because in the one, you've got patients who are post-recovery from usually elective surgery, and they're not at particular risk of infection. And the neonatal unit, you've got tiny little babies who've got invasive devices in every orifice, and you can't compare rates of infection on those 2 units. And so, of course, the study was a disaster. Not many studies like that get as far as publication. These kind of studies are understandably not done very often. So we said that you can't always do a trial. And so I'm going to give you an example of a condition where a trial isn't possible. Now, in these lectures, as far as possible, I give examples about infection prevention, but occasionally, as with the aspirin, I give you other kind of examples because they make a particular point. And this particular example comes from somebody who worked with me some years ago. She was a cancer nurse. She worked in a chemotherapy unit. She was a vascular access nurse, a very senior one. And the research question that she wanted to pose was, is a saline washout more effective treatment for extravasation in cancer chemotherapy than a commercially available antidote? You may be aware that extravasation occurs when the fluid that's being used to treat the cancer, the chemotherapy fluid, seeps out of the intravascular line and seeps into the tissues and is extremely damaging. So you can't leave it there because the limb that it's going into, the tissues would be extremely badly damaged and might even be lost, might get necrosis there. And saline washout is an inexpensive treatment for washing out the chemotherapy agent, whereas the antidote is very expensive indeed, but it's quicker. But the staff need training when a saline washout is conducted, but to give the antidote, it's just like giving an ordinary IV drug. So it was a very sensible research question to have asked. This is a slide that I often use to show people the effects of extravasation, and you can see that this person's got a red tide running down their arm is swollen. You can see that the extravasation, if it was allowed to progress, would be damaging. So there are challenges to designing a trial for this situation. Not many people develop extravasation. We read a lot about it, that it's a hazard chemotherapy and a well-known one, but fortunately, not many people get it. getting a sample that is homogeneous, getting a sample of people that are the same, is going to be very difficult, because although extravasation can be extremely serious, there are some cases of it that are more serious than others. So some people are more severely affected. And in any case, running a trial would be very difficult, because people with cancer tend to die, and older people tend to die often of other things anyway. So the average age of the person that you would get to take part in a trial like this would be very considerable. So although this is an important research question, really doing a randomized control isn't going to be practical, because you just couldn't get enough people to take part. They wouldn't be similar enough, and the trial couldn't run for long enough. So when in these situations a trial isn't possible, we do an observational study instead. And it's important, as Nick Black said, to do an observational study as well as possible, instead of doing a trial that's not very good. So that the study to do with cancer extravasation did take place, but it didn't involve a trial. Observational studies are of different kinds. Some are more rigorous than the others. And I'm going to talk about each one in turn. There are interrupted time series studies, uncontrolled before and after studies, which are pre-post test studies, a thing called cohort studies, and case series studies. Doesn't matter if you've never heard of them, because we'll go through each entire turn. Interrupted time series studies look at trends in data over time. And they're advantageous because we can assess variables, factors that are likely to influence the outcomes of an intervention over time. This is particularly useful in infection prevention, where we said that time of the year, seasonality might affect findings, where sometimes a study has to go on for a long time, new policies might be implemented, there might be changes in clinical practice. Interrupted time series studies are becoming increasingly popular. We use them to look at the impact of policy changes, new guidelines being introduced. They're used outside of research, in marketing research as well. And ITSs track changes over time, and they compare data before and after the intervention at repeated time points. They're very convenient when we collect routine data anyway, which in infection prevention, of course, we do. We monitor our MRSA rates, we monitor C. diff rates, we monitor rates of other infections in every trust in the country and in private hospitals, because by law we have to. And we all audit hand hygiene, and we do many other audits as well. Interrupted time series studies can be prospective or retrospective. A prospective one means that we collect data from the outset, but if you've got routinely collected data like MRSA rates, you can always make some change, and then you can go back and look at data that were collected before, because it's available anyway. And how the studies are analysed is we draw graphs. So epidemiologists who do this study draw a lot of graphs. The downside of this kind of study is they can be complicated to analyse, especially if a lot of changes occur, especially if they go on over a long period of time. A good example of an interrupted time series design was one that was done some years ago in the States. And there, the infection prevention team noticed that rates of C. diff had increased in 3 hospitals. They did routine surveillance for C. diff, just as we do here, and they had that data retrospectively, and they decided they would have to do something about it. So they introduced bleach to decontaminate rooms after patients had gone home. What you might remember from the lectures that we had before is that C. diff forms spores, which are extremely difficult to eradicate. They live in the environment for many years, and bleach kills the vegetative bacteria. So they were anticipating there would be a reduction in infections after they introduced bleach for cleaning. And after they introduced the bleach, they carried on, and they did routine surveillance, and they looked at C. diff rates over 10 more months, and then 24 more months. And in fact, they got a 48% reduction in C. diff rates after the intervention. And the graph that they drew looks like this. This graph was given to me by Dr. Dre, with whom I do a great deal of work. We worked together yesterday on something. And this shows us the rates of C. diff infection and time, the number of months goes by in the bottom. And if you peer at the slide hard enough, you can see that there's that red dotted line running up about a quarter of the length along the graph. And you can see that infection rates before the intervention before the bleach was introduced were up and down, and they go up and down afterwards, influenced by things going on in the environment. But there is a definite trend, if you look at those figures, for the rates of infection to have gone down after the bleach was introduced. So the intervention did work. Uncontrolled before and after studies are often called pre-test and post-test studies. In these studies, we collect baseline data, then the intervention is introduced, often in infection prevention, a new guideline or a new product. Then follow-up data are collected. There's no control group. Everybody who takes part in the study gets subjected to the same intervention. So the individual people act as their own control. But the downside is that you can't tell how typical the settings are. Supposing you did this study in a ward where you had a dragon of a ward sister who made sure that everybody washed their hands. Well, you can't say, well, this ward is typical to wards everywhere, because uptake of hand hygiene is not very good. So, the very fact that you're able to do the study at all might be influenced by the fact that this is a special kind of ward. So uncontrolled before and after studies are placed quite low down the evidence of the hierarchy of evidence, because they are subject to a great deal of bias, a lot of bias. And that's illustrated by this study, which is very old now, but I tend to pick out studies which are easy to follow and easy to look up for you if you want to. Bischoff, working in France, wanted to look at alcohol hand rub and its effect on hand hygiene adherence. It was a French group, but they were working in the US, and they worked in intensive care units, general medical wards, and coronary care units in one hospital. But they had baseline data collection. They found a very low rate of adherence to hand hygiene, 19%. They had 6 teaching sessions. They gave people feedback on their performance of hand hygiene. They introduced the alcohol gel for the first time, and then they audited hand hygiene afterwards and found that it had gone up to 41%. But they didn't have any control groups. Although they involved different units in the study, there was no control group. Everybody got the hand hygiene gel. The point is, we don't know whether the results would have been the same in other hospitals. Cohort studies are sometimes called longitudinal studies, and they come quite low down in the hierarchy, but they can be very useful, and they often are very widely done. They're used to explore the incidence and the cause and the prognosis, the cause or the course of a condition, often a new disease, and identify risk factors for that disease. And we use them to examine the association between exposure and outcome, so between an intervention and what happens afterwards. And what we do is we follow up a group of people who have a common characteristic, and we compare subgroups of the population, but we don't actually do an intervention ourselves. Things might occur, and we look at differences between things that might occur to different people in the group, but we don't do any manipulation. So that's why it's not an experimental study. Cohort studies can be prospective, or they can be retrospective if they routinely collect data. The most famous example of all is one that you might have heard of, conducted by these 2 people, Doll and Pito. Doll and Pito were doctors who began their work in the 1950s, and they looked at mortality, risk of death related to smoking in British doctors, starting from the 1950s onwards, and they're still at it. I think only one of them is alive now, but still the study goes on. And they compared outcomes for smokers and for non-smokers. Cohort studies can be extremely time-consuming. They're often expensive, especially if they involve lots of people, and they often go on for a long time. And of course, they're prone to bias and confounding. If you were taking part in a study that was looking at your smoking behaviour, and people were going back to you every couple of years and saying, oh yes, are you still alive then? How are you now? Short of breath, are you still smoking? That might actually prompt you to give up smoking or to reduce smoking. So you can see that just taking part in the study is going to bias your behaviour. And if it's a retrospective study going on over a long time, then the data may be incomplete. You may be using data that were designed for something else. But cohort studies are often used to investigate outbreaks of infection-related illness. And a nice example that I found on the web was one that took place in Italy a few years ago, because cohort studies are used to investigate outbreaks of food poisoning. And these kind of studies go on all of the time in all countries of the world, all countries rich enough to look at outbreaks of food poisoning. This outbreak of food poisoning took place in 2015. 24 members of a sports team ate a range of different foods in a restaurant in Umbria, which paradoxically is meant to be one of the eating parts of Italy. It's famous for it. And 24 of these people got diarrhea and vomiting. They got severe abdominal pain within 3 hours. So it's probably an example of food intoxication. Remember that I talked about when we talked about medical microbiology a few weeks ago. And 11 of these people were ill enough to go to the accident department. So they were pretty ill. And 18 other people eating in the restaurant at the same time didn't get any symptoms at all. So they did a retrospective cohort study. They compared people with symptoms and people who didn't develop symptoms. And they looked at people by giving them a questionnaire to look at what they'd eaten and what they hadn't eaten. This wouldn't work if the outbreak had taken place a long time before people developed symptoms, but over a period of a few days, people would be likely to remember what they've eaten, I think, especially if they became ill after it. They also obtained food samples from the waiters, from the kitchens, and they swabbed the waiters and the cooks. They swabbed the environment, including the kitchen. And what they found was staphylococcal enterotoxins in the chantilly cream in the dessert that the people who developed the infection, developed the symptoms, had had. The dessert consisted of chantilly cream. At the bottom, I've written down what the ingredients of chantilly cream are. Cream, sugar in capital letters, because staphylococci, of course, love sugar and breed to make in large numbers in sugar and produce lots of toxins to cause the intoxication. And there's just some vanilla flavoring in there as well. And the chantilly cream dessert was stored out of the fridge for 5 hours. So you can imagine what a reservoir of bacteria there were in it. And 5 staff tested positive for the same bacteria and the same toxin. Now, that is not such strong evidence as a randomized controlled trial. But under these circumstances, you couldn't have a randomized controlled trial. You couldn't, it would be irrelevant. It's just not that kind of situation. And the result is pretty persuasive. So these are the kinds of studies that go on in the real world, and the public health bodies conduct them all the time. Case studies series come further down the hierarchy altogether, and they describe patients in their natural setting. They can be retrospective or prospective, and they're different from cohort studies in that they don't seek to compare groups, but they compare sequential numbers of patients. Sample sizes are usually very small, especially if it's a rare new disease being described. But if people publish their studies, it's usually at least 3 cases that they describe by convention. These are not, people talk about case studies series as though they're quantitative studies. They've been around for many years, but I think if people were describing this methodology for the first time now, they would be properly classified as some kind of qualitative study. They do come down quite low down on the hierarchy of evidence, but they are important studies nevertheless, because they draw our attention to things that we wouldn't otherwise know about. When a new disease is described for the first time, like Zika virus or some other kind of infection, it's case series studies that are being described, and they're described in some of the most influential journals. So they are important studies. An example of them is an example of an infection caused by rhizopus, which is a fungus infection that occurred in a neonatal unit. This study occurred a long time ago, but it's a very memorable study, which is why I choose it for you to talk about. It was given to me, first introduced to me by a colleague, Dr. Purcell, who was once one of my students, but now we do a great deal of our work together, and he is a children's nurse. This was in a neonatal unit, which is how he read about it. 4 babies in the neonatal were described. They got a rhizopus infection. Remember, we talked about rhizopus as an example of a fungal infection when we talked about medical microbiology. 4 babies were affected, and of them, 3 died. It was very hard to trace the source of the outbreak. The environment was swabbed. No environmental contamination was found. There was no cross-infection. The cases weren't on the unit all at the same time. In the 1990s, it was very hard, much harder now than it is, to go on the World Wide Web find other similar cases happening. The World Wide Web existed, but their databases were far less easy to navigate today. But eventually the research team found that there were cases of rhizopus infections and pulmonary infections among people who worked in sawmills, I think mainly in Scandinavian countries. So they looked for sources of wood on the unit that might be harboring fungal spores, and eventually they found them. They found that the little babies were developing the infections from wooden tongue depressors. The children were far too tiny to have conventional splints for intravenous therapy, so tongue depressors, which are only a few inches long, were used, and the tongue depressors were contaminated with spores of the fungus, and they found their ways into the IV cannulae. And when they removed the wooden tongue depressors, which were only conventionally cleaned, they hadn't been disinfected or sterilized. When they were removed from the unit, the outbreak ended. The terrible lesson there is not to use clinical equipment except for the purpose that it's intended for. So this is a rather sad little study, but it is a very memorable one. Andrew Wakefield is famous, or perhaps infamous, for making the link between the measles, mumps, and rubella vaccination and autism in the 1990s. And this was an example of fake news because Wakefield cherry-picked his examples of children having autism deliberately. These weren't consecutive children who became ill. He searched about to find them, and he published his paper in the Lancet, but it was a very poor peer review. There was gross misinterpretation of the data and widespread reporting of fake information, and it led to a huge international outcry and wasted a lot of academic and clinical time trying to find out whether Wakefield was right or whether he wasn't. And of course, he wasn't right. There was since there's been found to be no link between MMR vaccination and autism at all, but Wakefield in the States is still trying to say that there is. A lot of people no longer believe in vaccines because of this, and there's a danger of extrapolation from a few selected cases. So there is a big difference between fake studies and a real, properly written up and conducted study like the neonatal one that I've just shown to you. So what can we say about evidence? Infection prevention. Is it really evidence-based? Are there many infection prevention measures that are underpinned by really high-quality evidence and robust RCTs? Well, there's the cleaning study in Australia, but it's an unusual study because most RCTs in infection prevention aren't very rigorous. There are a lot of barriers to undertaking them. And in any case, evidence is quite a fluid thing in infection prevention. Now, if you haven't really enjoyed the first part of the lecture or you found it difficult, this is the part to really concentrate on. And this is the important part that's coming now. And I'm going to talk about each of these things that we've just mentioned in terms. For a lot of the time with infection prevention, it's simply not possible to conduct a robust trial. We all know that sinks become contaminated really easily with large numbers of bacteria, and that if they found their way into a vulnerable patient, they could cause infection. Some people have developed self-disinfecting sinks, which you heat up or disinfectant gets poured down them at regular intervals. And theoretically, that should destroy the bacteria, and these sinks should reduce risks of infection. But self-disinfecting sinks are very expensive, and it would be practically impossible to be able to put them on enough wards to be able to run a trial. So the cost of the technology means that there are no, although the equipment exists and people do buy it, the cost of the technology means that, in fact, there are no trials to prove that it works in practice. In theory, it should, but in practice, we don't know whether it does or not. It might not be possible to convert the whole unit to a new technology. You could, in theory, do a great big cluster-controlled trial with lots of different ITUs acting as a unit of analysis, but these trials would be, astronomically expensive. So there are no randomized controls of self-disinfecting sinks or of other very large, sophisticated equipment in infection prevention. Then for infection prevention, there are a lot of ethical considerations. Traditional infection prevention measures have been in place for years and years and years and years and years. they make sense. I mean, put infectious people last on the operating list. We isolate people who've got infections, and we have done since biblical times. So we'd be brave to put somebody with an infection in the middle of a ward. But whether or not isolation really works, well, a lot's going to depend on what kind of infection it is anyway. But we certainly have never done any trials. It would be very difficult to do such a trial. And many traditional measures don't cost very much anyway. Writing an operating list in a particular order and putting the patient with the abscess on last after the patient with the hip replacement doesn't cost a lot of money, really. Many of the interventions that we do in infection prevention are effective in theory anyway. In theory, we know that alcohol-based products kill pathogens, and we know that from laboratory studies. No ethics committee in the world would allow us to do a trial to find out whether hand hygiene worked by having a control ward where they didn't do it. It wouldn't be acceptable to patients. It wouldn't be acceptable to us because we want to clean our hands. But ethics committees exist to make sure that that kind of thing doesn't go on, and it would just be dirty. You're never going to have a trial like that. Then their lack of persuasive outcome measures. People think, well, infection prevention rates are nice hard outcome measures. You can measure them, but then some infections are asymptomatic. We know that many of the COVID infections were. And then we know that whether people develop an infection or not, whether they develop signs or symptoms, depends a lot on the patient. Can you compare a cancer ward with a ward where people are having elective minor surgery? You can't compare cancer patients with otherwise fit patients having their tonsils out or having their uterus out or their gallbladder out because you can't compare apples and pears again. They're different. Often studies use proxy measures. Infection rates are difficult to measure, so often people just measure hand hygiene as an indicator of infections, but they don't actually represent infections. But the danger of that is you get a situation like Rupp. He managed to increase hand hygiene adherence in his study, but it didn't count for very much because he couldn't manage to reduce infection rates because he was using a bad kind of hand hygiene. Wasn't hand hygiene product. It wasn't the right concentration. And if you're going to measure infection rates, you've got to measure colonization rates. Now, you can pick out in people with infections that are symptomatic because you can see the symptoms, but colonization, people who are colonized have no symptoms, as you know, from the first teaching sessions that we had. So it would be very expensive to get specimens from everybody to know whether they were colonized or not. So that's another difficulty. And then, of course, we come back to our old friends at confounding variables. Straight away, we know that trials are going to be heavily influenced by the season because of infection rates are more common at particular seasons of the year, and they're going to be affected by cyclical trends, and they're going to be affected by secular trends. So we know, again, that these kind of trials are going to be affected by a lot of things that we can't control. And it might be that the intervention that we try to import fails, and we might not know why it fails. The intervention might not be any good, like that one with poor old Rupp, or the health workers might not comply with the intervention because it's too difficult or too apathetic. And there are examples where people have tried to implement hand hygiene and tried to increase hand hygiene, and it hasn't worked. In the study by Fuller that was done in this country some years ago, the ward sisters were supposed to be responsible for the intervention. The research team was too small to go into the wards to deliver the intervention, so they depended on the ward staff for doing it. The intervention was watching the nurses as they went to the patient, and then if the nurse came away from the patient without cleaning their hand, or went to the patient and didn't clean their hands before touching them, the ward sister was supposed to say, "Now you're supposed to clean your hands, go and do it, please." But of course they didn't like doing it because they knew that their nurses didn't like being reprimanded or corrected in front of the patient and the rest of the ward. So the intervention never really took off, and the study didn't really work. The method of data collection might be flawed. Hand hygiene is often done very inaccurately. The study design might be not very good, and we might draw the wrong conclusions from it. Or the outcome measures might not be very good. Infection rates are very easily influenced, as we've said, or it might be a combination of all the factors. And that means that really doing a trial in infection prevention isn't often something that we can do very well. Successful interventions are more likely to be published anyway, and they get most publicity if they are published. An awful lot of studies may be done and they may never see the light of day. So in infection prevention, very often we're relying on kinds of study designs that don't come up very high in the intervention. So where does that leave us? Well, it's important to implement interventions where there is proof of effectiveness. It's important where, according to logic and common sense, an intervention should be effective. So cleaning your hands with alcohol hand gel is a good thing to do because we know alcohol hand gel does kill bacteria in the laboratory. It's important not to bother implementing interventions whether the intervention is not logical or not successful. There is no evidence whatsoever that wafting oxygen over a wound to dry it out does any good at all. It probably does damage. And putting lead on somebody's skin is certainly not going to do them any good. It's probably going to be dangerous. So I didn't have that terrible Ward report all those years ago for nothing. So evidence synthesis can help us. People do systematic reviews where they look at the results of lots of studies and they publish them. And you may never do a research study yourself. You may never read a research study again after you've looked at this course, but you might be very grateful to read systematic reviews and be very grateful for the way that they're done. And decision-making and the way that systematic reviews are presented is important. So systematic reviews come very high up the hierarchy of evidence. They save time, they save resources, because clinicians are busy people. You can't possibly expect a busy nurse at the bedside or a busy junior doctor or a consultant or a GP to read lots and lots of studies and evaluate them all themselves. That's what a systematic review is supposed to do for you. And the people who do systematic reviews collate all the evidence together to answer a specific research question. The research that goes into a systematic review has to be very good quality, and the quality of it is designed before the review is set up. There are eligibility studies to say, well, we will include this kind of study, and we will include properly conducted trials, but we won't conduct before and after studies because they're not the right quality. The systematic review explains in the title what it is really. The method has to be explicit. You have to have a protocol describing exactly what you're going to do. The way that you go about doing the review has to be reproducible. In other words, it has to be systematic. And the aims are to assess the validity of all the studies that are included, to minimize bias in them, and to give reliable findings to inform policy and practice. And they can also suggest areas where other research hasn't been done. It may surprise you, but there are lots of areas in infection prevention where we just don't know the answers because the research hasn't been done anyway. And when we write up the results of the systematic review, the people doing it present the characteristics of all the studies that they looked at and the ones they excluded as well. And they tell you why they excluded them. And they explain very precisely how they did their critical appraisal using a named critical appraisal tool. There are lots of systematic reviews in infection prevention. There are over 20 that just look at hand hygiene. And the one that you might like to look at is the one that we did in 2017. We're just doing it all over again now. We do this review every few years. For the past 3 times we've done the review, I've led it. This time I'm taking part, but somebody else can have all the work of leading it again. And what we looked at was interventions to improve hand hygiene compliance in patient care. And you can just put those words into the database and Google, and you can call up the research. The systematic review is many pages long, but you don't need to read it all if you don't want to. One of the features of Cochrane reviews is that there is a summary at the beginning, which is for lay people. So it's a good idea if you're interested in the Cochrane reviews, just to read the lay summary. They are very well put together, not because I particularly put ours together very well, but because they show you how to put the review together. It's very like following a recipe. So hand hygiene is my particular area of research expertise. I look at other areas of infection prevention as well, but hand hygiene is my special area of expertise. So I've been involved in doing the Cochrane reviews for a great many years. The challenges of systematic reviews, though, is that they're not perfect. The research questions are always very narrow. We look at a very narrow area of practice. In the hand hygiene one, we look at at the study design of the hand hygiene studies and whether the trials were any good or not, but we don't look at how well they audited the hand hygiene, which is another important thing that probably should be included because I think it's important we've published separately on that. And the other thing about systematic reviews is a review might be undertaken absolutely rigorously, absolutely perfectly well, but the quality of the individual studies themselves might not be very good. The first time that we did the hand hygiene review, which was in 2007, it's a long time ago, there were only 2 studies that were good enough to be included in all the wide world. In 2009, there were 4 studies that were good enough, and they still weren't very good. And in 2017, I think we looked at over 4,000 papers. It was very hard work. These things are very time consuming, and we included about 20 studies, which is not very many out of the total that we looked at. And it is possible, sometimes people do systematic reviews and there's no evidence of the research that the interventions work. So systematic reviews are very good when they exist. And meta-analysis is when you pool statistics all together and combine all the evidence from all the relative studies. And that gives us better effects of interventions than interventions from single studies. But they only make sense if all the studies are the same. For example, if a study took part, if one study to look at hand hygiene took place in Australia, and another took place in Nigeria, and another took part in South America, it would be very difficult to compare them because you're comparing them from different areas of the world, very different kinds of healthcare. So the clever part of doing a meta-analysis is not running the statistical program, because your computer does all that for you. All you've got to do is plug in the numbers, and then the computer program will do the rest. The part that takes real thought is deciding whether a meta-analysis will make sense in the first place anyway. If the studies aren't all the same, if they're done with different populations, if the outcome measures are all different, if the interventions are all different, it's not sensible to do a meta-analysis. And for that reason, we don't do them with the hand hygiene review, because all the studies are very different. So let's sum up. It's difficult for us to respond to change because we've got to respond to it. Patients change, healthcare changes, and how we deliver care and where we deliver it changes. It certainly has over my long professional lifetime, and it will change over yours. Infection risks change as well. There are genuine changes, or there are ideas that change about them. Before the pandemic, people thought that flu was spread by the airborne route. Now we think that flu is spread by all sorts of different routes as well. People thought that coughs and colds were spread mainly by droplets. Now we think that when the pandemic first entered our shores, we thought that COVID viruses were probably spread rather like coughs and colds in large droplets. But now, with a lot of research that's gone on, particularly research into the indoor air environment, we know that probably COVID is spread at least far more by air than it is by direct touch, and that respiratory protections are much more important than at the beginning of the pandemic we thought. Pathogens change as well. We can't alter how they behave. We can alter how they behave, but we can't destroy them. We can pour disinfectants on pathogens. We can put alcohol hand rub on them. We can do all sorts of things, but we can't destroy them. Bacteria were here before us. Viruses were here before us. Then they've adapted to the environment. They'll go on adapting. When the world comes to an end, they'll probably be here after us. They'll outlive us, all right. So we have to learn to live with them, because they're always going to be with us in healthcare. We can do things to make them change. We can alter the way they behave, but we can't get rid of them. We never will. Rhizopus was once thought to be a fungus that didn't cause infection, and today we've had evidence that they did kill 3 babies, and they had to be controlled in the unit where they were and removed, but we can't remove them from the world. So we can learn how to manage pathogens, and the way that we think about infections alters. So infection prevention and control, our big challenge is that healthcare is supposed to be evidence-based, but few infection prevention interventions are underpinned by very good quality evidence. And one of the things that you have to bear in mind is that doctors are very keen on randomized controlled trials. It's part of their training. They learn far more about trials than nurses do, far more. It's part of their training. And they're very skeptical if there isn't a trial to underpin it. People who've done this course, attending follow-up days, say, doctors will say, well, I don't believe in things. Somebody who did the course, a junior doctor said to them, "Oh, I don't believe in bed below the elbows. There's been no randomized controlled trial to prove that bed below the elbows works. And until there is, I'm not going to do it." Well, of course, there's no trial to show that bed below the elbows works. It would be far too difficult to design such a trial. It would be far too expensive. You'd need millions of people. The outcome measures would be very difficult. And in any case, bed below the elbows costs nothing at all to do, and it's quite sensible and common sense. So really, somebody saying a thing like that betrays enormous ignorance. They're not being clever. But junior doctors are very mischievous. This doesn't mean to say I don't like doctors. I do like doctors enormously. I've just done a big piece of work with 2 doctors who are entirely lovely to work with, but they tend to like trials very much, and they can be mischievous and they can be very challenging. On one occasion when I had very bad eye infection, I was in Moorfields Eye Hospital. I had one eye infected at the time, but I couldn't see really what I was doing, and I thought that there would be a big risk of cross-contamination from one eye to the other. The pharmacologist prescribed me or dispensed, that's the word, dispensed me with eye drops for just one eye. And I said, "Well, isn't there a risk I might get infection in the other?" And the pharmacologist, without pausing for a breath, said, "Oh, no, not at all. They've done great big trials and there's no risk of cross-contamination or cross-infection from one eye to the other at all." And I was far too ill. I felt ill in myself. I was far too ill. And there were too many people about for me to tell the pharmacist that he was a silly fool. But of course he was one, because no such trial has ever been conducted. It would be far too expensive, and chloramphenicol eye drops are very cheap. So it wouldn't be in anybody's interest to try and conduct such a trial. So for many infection risks, many infections, it's very difficult indeed to run a trial. So we need to understand the methodological limitations of study designs. We need to be able to defend practice that is logical and acceptable. And you need to know your local setting and risks and needs. And the topic of the next session is going to be about that. But before we finish, I want to tell you about the parachute study. It's a very famous study, and you can read about it in the BMJ if you want to. Every year before Christmas, the British Medical Journal publishes a special paper, and it's not labelled. You have to pick it out. You can't tell it from anything else that appears in the journal. And this particular study was about whether using a parachute, the research question that they posed was, does using a parachute prevent death and major trauma when you jump from an aircraft? And the people who wanted to examine this research question did a randomized controlled trial, and they wrote a protocol. The idea for doing the study arose when this group of young people were attending a conference. They attended the conference somewhere in the States, and the conference was all about evidence-based practice. And it was pointed out to these people that it would be very difficult for them to do any intervention without evidence, and of the importance of high-quality evidence when delivering health care. So on the plane going home, these people became very giggly. They'd been in the conference for 5 days. And when you've been away at a conference, staying in an hotel for 5 days, it loses its novelty. You're glad to be going home. You have a drink from the free drinks trolley. You get more giggly. And eventually somebody said, wouldn't it be fun to see if you jumped off this plane, whether it actually killed you or not? And somebody said, well, we ought to test whether a parachute would make any difference. Is somebody more likely to be killed if they jump from the plane flying at high altitude if they're wearing a parachute or if they're not wearing a parachute? So these people came home and they designed and did a trial to test exactly that. So they wrote a protocol and they designed their research and they had their test and their control group and they got their sample of other young people that they knew. And they had a placebo. The people in the test group wore a parachute. The people in the control group didn't have a parachute. They had an ordinary backpack that wouldn't inflate. They didn't want to hire, they couldn't afford to hire an aircraft. So what they did was they hired a helicopter and they got people to leap from the helicopter wearing either a backpack or a parachute. And when they did their statistical analysis, they found that there was no difference between the people who wore the parachute and the people who wore the backpack. In fact, there was no incidence of trauma or death in their study whatsoever. And you read this, and this paper is written up completely deadpan. And you read your way through the study before you realize that you are being had. And if you read a hard copy of the journal, you probably won't, you probably read it online. But eventually, toward the end of the paper, there is a picture of the people jumping out of the helicopter. And what they don't tell you until the very end of the study is, of course, the helicopter never leaves the ground. So the people who are jumping out of it only jump a few feet. But the paper is humorous. Every year, the BMJ publishes a spoof article before Christmas. And this was the spoof article in 2018. But humorous though the article is, it conveys a very important point. Randomized controlled trials are expensive, they're difficult to conduct, they're time consuming, and it is very difficult indeed to conduct a good one, and almost impossible in some areas of clinical practice, of which infection prevention is one of the main ones. So the point is that you don't need a great big trial that costs hundreds of thousands of pounds to point out the obvious, that of course if you leap from a plane without any kind of protection when it's flying at altitude, of course you're going to perish. But you don't need a big expensive trial to find that out. Okay, so the parachute study has been read many, many times. It has thousands of citations. If you look it up, you find that it's lots and lots of people have read it, lots of people have cited it, because it makes its point very eloquently, as well as making it in a very fun way. So the lesson from the parachute study is that we don't need a great big expensive trial when common sense would tell us the answers anyway. And that is true of an awful lot of infection prevention. If somebody says to you, well, I can't be bothered with bare below the elbows because there's been no RCT, the answer to them is to say, well, go and read the parachute study then. Go and read the parachute study and see if it will change your mind. That's what you need to say to silly people like that. So let's have a short break now, and then we'll go into the second lot of today. Right. So the aims and objectives of this session is to design an infection prevention strategy to meet local service needs. And at the end, more quickly, we're going to have a go at critically appraising a study. So there are going to be two activities that we're going to do. We're going to design our strategy, and then we're going to critically appraise a strategy, working in three groups I think we've got. So I'll introduce exercise 1, designing infection prevention strategies to meet local service needs. So just imagine you've been asked to update the policies for hand hygiene and PPE throughout your organisation. What you need to think about is what factors you'd consider when updating your policy, what information would you draw on, how would you proceed with implementation, and how would you evaluate your updated policy? It's fair to point out here that when we've had feedback, when the other groups have been providing feedback with past cohorts, a lot of people consider implementation, but people are not being quite so good at considering how you'd update your policy in the first place and what you'd think of to do that. And people haven't thought so much about evaluating it either. So all 3 points are important. So it's very important to consider the evidence base, the research and other sources of information that you take into consideration, national and international policy, adapting your policy to meet specific organisational needs and needs in different parts of your organisation. Remember, you've got different occupational groups there. You've got different ways of working. One way of doing things doesn't fit everything. You know, what you do in the intensive care unit or the operating theatre doesn't work on the care of the elderly ward. So if you've got a generic protocol you're going to implement, you've got to think about the different areas. And you've got to remember also about organisation and expertise. Infection prevention is multidisciplinary, so who's going to help you there? So what I've allowed here is 20 minutes, I think, for group work, and then we'll feed back to the groups when we come together. And we'll see how you're getting on after about 10 minutes to make sure that everybody's focusing on the topic. So maybe we can get into our groups now. Let's have feedback from the groups. How many groups did we have? 3.
We had 3, but I didn't notice 1, 2, or 3. So I think, you know, just probably get somebody to speak for any of their groups or anybody that wants to give us some feedback.
Have we got a spokesperson in each group?
I mean, Oh, I can see Manisha's nodding. Is
And
that you? Or is it somebody
now because I've
else?
got the slide up, I can't see who's doing what. So let's
Control
go
me to
with
take
this.
it down.
Yeah, we can. So we our aims we discussed a bit till objectives, like bit of objectives. So our aim is to like how much we understand to update the policy or to look up the policies and update it to achieve or like improve hand hygiene compliance and the PPE compliance to us maybe to a certain percentage or like more. Um, so we could say maybe 100 percentage, which is not, I'm not really sure, but 100 percentage if we say like that. And with the background, we wanted to look up the studies that
Good.
with the
Good.
um, studies that would say the current practices, like how where we are at and what are the different studies that has been conducted to see what are the factors that are still influencing this hand hygiene and the PPE compliance, like where are we at. And so our objectives can be to look up the local policies and the national policies and the organization policies, like what is the current policies that where we are, and also the audit reports and audits and or the surveillance reports of how much percentage are we at each organization, because it can be different in a hospital, it can be different in a community and in the other kind of setting. So we need to look up individually where we are at in our specific organization. And then the second objective that we is to identify the barriers or the factors by collecting up data to know whether it can be qualitative mostly to how do I put it, to identify the barriers that can like be a barrier to the hand hygiene, or like what are the factors that where we need the improvement in our plan, where it's a gap that we feel that we need to fill that gap. So maybe a gap analysis, like where are we at and what are we aiming for at the particular this in this. And next once we identified the factors and this one, then we can try and implement, collect data and look up the previous researches where somebody has done anything for that factors, and then we can try and implement it, to talk to the stakeholders and try and get involved with the various department, and then try and involve with them, like understanding the stakeholders, what they want to do, like what we to put up our own ideas. And last is to check, evaluate our effectiveness of the outcome that we are expecting it, that with the factors that's the pretty much we did.
That's as far as you got.
Yeah, that's as far as we could.
But that's as far as you got. I won't ask you how you're going to evaluate effectiveness because you didn't get that far. So it's quite a lot of material to get in 20 minutes, really, isn't it?
Yeah.
There's a lot there. But that was good, because other groups tend not to think very much about what or why they're going to do this exercise. But there's usually, if people decide they're going to increase their hand hygiene compliance, they've usually got some information there that it needs increasing. Have you got any idea what the rate of compliance is in your departments? Do you actually know?
Yeah, for this project, I took it from the infection control team, and it was 94% in hand hygiene.
But do you believe it?
Because I work in at the bedside as a staff nurse, so I feel like, I mean, it's like the audit. I mean, I'm not really sure, but it's like I said, it's a SWOT. Like there's a lot of factors that are involved in the schedule and the workload. I'm not really, I don't think so, but yeah, that's. But it still requires a lot of improvement, because those who attend the audits, and I've been talking to the linked nurses and all, they said we still require a lot of improvement, because it's sometimes sometimes it's not really the audits and whoever taking subjectively whatever that's seeing, but there are a lot of portion that unseen, and what we are practicing. So I think those areas needs more improvement.
Should we have 100% hand hygiene? Suppose the patient is there going navy blue. Do we want hand hygiene then?
Sorry, what?
Supposing the patient is there going that special colour of navy blue. Do you want hand hygiene before you touch the patient then?
Uh, if it's part of the hand hygiene, how the like the moment. So before we, uh, like, so if you took a handover and then before we do a hand washing and then you approach the patient, so that's a practice that we need to follow. I mean, ideally, yeah.
But in a real emergency, it's not always.
No.
It's
In a
not
real
always.
emergency, no. Yeah, code blue in kind of those kind of situations,
No,
we can't do.
it's not always possible.
Yeah.
Somebody who did their PhD with me was the chief infection prevention nurse in a very busy trust in the centre of London. And her PhD was looking at how hand hygiene is done in all the different departments of a hospital. And in the emergency departments, the staff there said, well, to be perfectly honest, if somebody is coming through the door after a major road accident, you have very little time even to think. We have to be perfectly honest. Whereas in the radiology department, is low risk department, actually they were doing almost nothing at all the time except clean their hands. They were doing it too much because they had the time. Because they had the time. So what was going on in some departments was very interesting. She got two experienced infection prevention nurses to watch the anaesthetize somebody, and there it was practically impossible to agree when a hand hygiene event should occur because what they were doing was so complicated and everything ran into one another. So that, it depends a lot. But there, you work very hard there. Let's have another group. Have we got any other spokesperson?
I see Stacey's unmuted.
Yeah, we were group 3, and we were quite an eclectic group really, because we had someone from charity, someone private, community, ICB. So the first question, we felt that we would review what was in place currently, whether it was working or not. And we had a conversation about target groups as well. So some of us have got kind of a standard across the whole organisation in relation to hand hygiene policies, and others have got them specific to designations. So we had a really interesting conversation in relation to that and the pros and cons for both, really. We talked about the need for national guidance for it to be referenced and best evidence, easily read by everyone and understood. And again, that came into that target group conversation, and also the need for IPC to be prioritised at inductions and mandatory training as well. Policy in place, so mandatory updating that governance structure and changing guidance. And we also talked about any change in guidance, how financially impactful that could be in relation to whatever organisation people were working in. So that, again, that generated some conversation. In relation to the second question, we talked about meeting with all stakeholders, putting the updated policy through IPC committee, or following whatever governance process they had for the organisations that were working in. We talked about, obviously, risk committee as well. And I mentioned that as commissioners, the policies would generally come to the clinical quality performance group as well, just for overview and for information and sign off. And then the third question, we talked about getting feedback from the users of the policy. Is it easily implementable? Is it easily usable? Was there kind of jargon in there, or words that could appear complicated, or there could be two elements of the use of a phrase. We talked about auditing, PRI meetings and sharing the learning, and looking at both the positives and the negatives in relation to situations or not having situations. So, if you were lucky enough not to have any IPC outbreaks, looking and reviewing the positives of that. And then if there had been outbreaks, what what had initiated that and the negatives in relation to it. The use of the wider IPC team, so across systems, not just kind of being isolated in your own areas as such. It's utilising them peer networks as such, and then meeting with the wider organisation to implement the new policy, and then obviously auditing in relation to that governance process and time. So yeah, that was what we had.
Good, that's very comprehensive. Can I ask you a question? I noticed that you mentioned training, and when people begin in an organisation, infection prevention is supposed to be emphasised in mandatory training and induction training. Does it not get very emphasised these days?
I mean, certainly from my point of view, as a clinician who works in commissioning, I do it separately because I keep myself clinically up to date. But the conversation that we had in relation to the induction was that it was included in induction, but it would depend which designation was doing that induction as such. So I think that element of it was very variable across our group. So yeah.
I mean, that's one of the things I'm personally interested in, because for the COVID inquiry, I was asked to write a lot about education, about guidelines, but also education, the educational preparation that people get for infection prevention. So obviously I wrote what I wrote, and what I said was that it is mandatory, and it is likely to be extremely variable across organisations. Yeah. So what you say is very interesting from that perspective.
Yeah. I can see Lindsay's got her hand up.
Oh yeah, I was in group 1, and I'm sorry I had to go and take a call, but so I don't know if you've reviewed our group, but basically we discussed everything that has been discussed by the other 2 groups, but I guess specifically in our group was around I think it was Razor mentioned about their IT unit potentially going water free. That's a big change, isn't it? You know, that's a big change for a lot of people. You think about hand hygiene, you think about soap and water, washing the hands. And do you need a separate policy for that, or is it covered in using soap and water or gel? And do you need something separate? I suppose the other thing for me, and it's more a question out to other people actually, rather than what we discussed, and it just came up when people were talking then about that kind of audit. And audit was a strong thing in our group, about audits are done really regularly to kind of evaluate. But actually I was thinking with the expectations of patients now, because there was a lot of emphasis on hand hygiene over the COVID period, and patients' expectations have kind of changed, and the knowledge has changed around hand hygiene. And I just did wonder, in audits, does anyone ask patients when they're doing an audit? Do they ever ask, you know, do you see, do staff wash their hands? What does hand, you know, it was just personal for me when I was thinking about, you know, doing this piece of work. Does anyone ask? Because I'm the same as Stacey. Stacey and I work in a very similar role. I'm a clinician, but I work in a commissioning role. And I just wondered, does anyone ask the patients?
I spotted both Karen and Nikki there. So Karen, I think you came in first, and then we'll come to Nikki afterwards.
Yeah, so in my trust, we do a separate audit for hand hygiene for patients, and we are working towards getting the patient educated. There's 2, I would say, categories that we look into. It's those patients who are able to wash their hands on their own, the mobile and, you know, the able ones. So they have a very good compliance when it comes to hand hygiene, because whenever we talk about it, on the very first instance that they come to the ward and say, the nurses are very good in saying that we're very big on hand hygiene. We encourage you to wash your hands and so on and so forth. And when we audit them, they have a very high compliance. However, it's actually disheartening to see that the compliance with hand hygiene for those that are unfortunately unable to do so on their own, some that are, let's say, intubated, and and then we try and give them clean, or those patients who have casts or slings, they do need help in performing their hand hygiene, and the compliance is a little bit low, because then it is actually dependent on the staff in terms of helping them out, especially before and after meal times. So this is where we are kind of working on at the moment as well. But yes, we do a separate one for patients.
Yeah, but in terms of like, that's great to hear. But in terms of compliance with the policy, so the staff policy, so it's kind of the staff who need to be compliant with the policy. Are patients ever asked about what their views are on staff hand hygiene? Because when there's doing an audit, everybody does it right, don't they? More or less. But because patients observe staff, they're sitting they're lying and sitting in the beds or sitting in the chair, aren't they, all day, and they do observe staff. And I just wondered, does anyone ever ask patients about what they
I
observe?
I can see Nikki's unmuted,
Yeah.
so I'm guessing Nikki wants to jump into that.
So yeah, part of our patient experience, and part of our which we call a PEEP audit, which is patient education, equipment and practice. We don't expect that to be 100% at all. In fact, we don't want it to be 100%. I'll send it back if it comes in as 100%. But yeah, we do something, and the patients are involved with that. Now, obviously, I've worked in a large trust, and I appreciate that I'm in a much smaller organisation now, so I'm at hospice. But equally, that's done as part of the inpatient, and it's also done part of our community group as well.
Great.
So
thanks, Nikki.
In infection prevention, the patient perspective is so often overlooked, and it's just assumed that people will not be very, members of the public won't know very much and won't be very interested, but they are, especially after COVID. They are. And you have to adopt the correct kind of demeanor if people ask. On which day was it? Last week? Maybe it was Friday last week. No, Saturday maybe. I had flu vaccination. And the pharmacist who delivered it immediately went to clean his hands after touching me. And I said, but shouldn't you have done that beforehand? He said, oh, I did that, but you didn't see me do it. It was out of your sight. And I said, I knew you were going to say that. That was what you said to me last year.
Ooh, hopefully he'll remember you next year then, Dinah.
I think I might go somewhere else next year. At least they had a sharps box this year. Last year they didn't have that.
Oh, goodness. So I think we got one more group to get some feedback from, haven't we? I don't know if there's anything that the group wants to add, or anybody else wants to jump into the conversation and discussion. It's a great discussion.
It's good.
It's really good. I think one of my most frustrating things. Oh, Anik, yeah, I'll come back to you now, Anik. One of my really frustrating things that I had when I was writing the policies is we had to write the policy according to the policy on policies.
Oh,
so
yeah.
you end up with all the preamble or the postamble. It's like that important bit in the middle often gets lost because, and you ask people to read the policy and it's like, okay, there's pages and pages. So how we got around that, particularly with things like the MRSA policy or the C. diff policy, we had like a pack at the back, an appendix that we called a management pack, which had just the critical information for people.
Just like an executive summary.
Yeah. Had to go to get it. So yeah. Anik.
I just wanted to make reference to, what was it, Lindsay, in terms of her question about patient participants are asking questions. So in the area work, it's like outpatients, we always give them a feedback form, and sometimes we randomly look at the feedback form and we notice a lot of patients always say the area is clean. And I think a few times they have mentioned in terms of like infection control, it's clean and like the staff always, how do I say this now? In terms of infection control with hand hygiene, they notice that we always wash our hands or use hand sanitizers. Because as I was explaining in the group, that where we work, every wall, there is a box of gloves, like large, small range. And under that box, there's always a hand sanitizer there, and there's a hand sanitizer and soap at the wash basin. So by the time you come from the patient, look, there's a glove box, there's a bin, clinical waste bin. But sometimes we have issues with patients discarding the appropriate waste in a correct bin. But otherwise than that, we've always got recommendations or acknowledgement in terms of we're always clean. So, and that kind of how do I say this now? That kind of, because in terms of infection control, we also get audited on our clean spaces. And that also prevents the transmission of infections going. So we always ensure that it's clean because we have housekeeping there, and trust me, she's very good at her job. And she always ensures that the bins are clean and they're emptied and all of that. So we have gotten acknowledgement in terms of clean and hand hygiene, but when it comes to our audit, we don't ask, like, there's no question there that asks patients about infection control, hand hygiene, that sort of stuff. So it's more about the staff than it is patients. But for the staff, we have to review what our infection control policies are, because we have an intranet. As you go on the computer, it pops up and it basically tells you the infection control policies that are updated, or what has been revised, or what we need to remember to do in terms of, now they're telling us how to wear our masks. So because it's flu season, winter season, they tell us what type of mask we should wear, whether it's surgical mask or the FFP3 mask in certain precautions. So it's always being updated at least quarterly, and it's always put on the internet to remind people. But sometimes people in the essence and workload, they tend to forget. But each time they go on the computer, they'll remember. But sometimes when it comes on to the precautions in terms of how you manage people with certain types of infections, especially CPE, MRSA, the information is not readily available. So most times we ask seniors and they're like, oh, I don't remember. So there's sometimes gaps in information, and when it comes on to that infection control, our mandatory training is like 3 years, every 3 years.
I'm gonna Annie, because that's right, I'm gonna move on because I see two other people with their hands up. So
sure, no problem. That's
okay.
That's what my
thank you for that contribution. That's really helpful. Faith.
Hello, everyone. Can you hear me now?
We can.
Oh, sorry, I forgot to unmute my speaker. I have a bit of a question for Diana. My other colleague, I think someone mentioned about a waterless unit. I want to know how effective that would be as relation to hand hygiene.
How effective what would be, sorry?
The waterless unit.
Nobody really, well, the effect, what the waterless unit is, it doesn't mean that there's no water at all, of course. What it means is in the clinical area near the patients, there are no sinks. They're removed, but you would still have the hand hygiene gel there. So you would still be using that, and you would have the sinks in other areas. So you would have as far as I know, because I've never actually been on a waterless ward, you would still have a conventional sink in a treatment room. You would certainly have it in a kitchen or a sluice. So it will be the patient care areas. Now, waterless wards are quite innovative, so the way that they're implemented probably varies. But as far as I know, there's never been any trial yet to look at their impact. And I don't know many studies that have looked at what they would call a pilot study to see how they're evaluated. And if you're introducing one in an area, that would be a good opportunity for a pilot study, to see, are they acceptable to people? What do the staff think of them? What do different grades of staff think of them? What do patients think of them? And what do visitors think of them? And what are the infection rates like compared with what they were before? It will be very difficult to do a randomized controlled trial. There would still be quite a lot that you could do to find out about them. Okay. And as far as I know, not really very much that is yet known. But I mean, even if it's waterless, you'd still get the hand hygiene gel there, and you would still have sinks in other areas. You'd have to, because if you have an outbreak of C. diff, you would have to have conventional hand washing.
Yeah.
Okay. Does that answer your question?
Yeah, it does. I have another question. Someone else also mentioned about auditing, and in my trust, I think the auditing on IPC is done by the IPC team, and is usually quarterly.
Yeah.
But I think it's not effective enough. This is just me personally. I think we should have an internal audit team, maybe within staff, so that we don't, when we grade ourselves, we know how to improve on ourselves before the IPC team comes and does the general auditing. How frequent do you think auditing should be?
Well, I could talk about that all day and all night, and we'll still be here next week, and we haven't got time for that. But there are issues about who does the auditing. So what you seem to be asking really is, should you have audits in order to get you ready for the master audit?
Yes.
There's no reason really why you couldn't have informal audits. There's no reason at all why people shouldn't look at you doing hand hygiene in the ward. But before you start doing that, do ask yourself, what training and what preparation do people on your ward have for doing that? Not long ago, I did a big piece of work about aseptic technique, and there is very little training that goes on in relation to aseptic technique compared to hand hygiene. And some areas, people were saying, oh, well, what we do is we look at YouTube videos, or we look at this, or we look at that. And what emerged was there is enormous variation, and some YouTube videos weren't all that good. So you can do all sorts of things, but you have to make sure that the quality of what you're doing is good.
I'm going to move on because I see Razor's got a hand up, and then we need to wrap up after Razor's question or comment.
Hi, my question is regarding the wearing of gloves. So with the 5 moments of hand hygiene, before patient contact and after patient contact. In these 2 moments, what we have observed during audits is that the staff generally wear the gloves and go, so that skip that before moment. And when they're done with the patient, they remove the gloves, and most of them doesn't clean or sanitize their hands, because the gloves are giving them a false
sense of security.
Yeah, false sense.
Yeah.
So what the justification that we were trying to teach them, so they were like, I'm wearing gloves. So we were trying to like rationalize why you need to. So then I had to like search for evidences on why to answer that question. Then finally I found the WHO's guideline. It says the donning and doffing. So we don't don and doff correctly. I think that I'm not sure. Is that the reason why we say they should be washing their hands before and after, or cleaning their hands before and after?
I could talk for a long time on gloves, and the Royal College of Nursing has done a lot of work around use and overuse of gloves, and has a lot of resources available on it, which I know are on the website. But the idea, the consensus regarding gloves is really universal. They do not remove the need to clean hands. You can't really clean your hands when you're wearing gloves. Applying alcohol gel to gloves doesn't really work. And when you remove gloves, you can contaminate your hands extremely easily. So gloves gives you a false sense of security. And the other thing is, if you're touching blood or with gloves, remember that gloves can leak. Remember that gloves can be damaged. Remember that gloves are permeable to tiny, tiny particles like virus particles. So wearing gloves is not a substitute for hand hygiene and should never, never, never be regarded as that. And remember, you did have the lecture on sustainability issues, which I think was a pre-recorded one, and Rose Gallagher gave that. But Rose is very strong on work around gloves, and that gloves do not, gloves add to what we discard and is not good for planetary health, and certainly doesn't do a lot of the time for infection prevention. I won't say any more, but I could go on a lot about use of gloves, but we just don't have time.
So I've just popped the glove awareness campaign link into the chat. Dinah, we've got about 10 minutes left. So
right.
we haven't got time. Well, I don't think we've got time to go into the group work.
Yeah.
To do this next bit.
I don't know if you group work.
If you just want to use your feedback on what you would have got them to do.
Right. Thanks very much.
With too good chat though to stop everybody at that point.
Yeah, no, that was good.
It was.
Right. So let's just talk about critical appraisal, and let's just remind ourselves that critical appraisal is a way of systematically examining research to assess its trustworthiness, its value, and its relevance. And it's not the same as criticism. So we're looking at research to say, can we believe the study findings? Are they going to be helpful? So let's critically appraise a hand hygiene campaign, and we'll do this all together instead of going in groups because we're a bit pressed for time, and I don't usually get individual feedback from people from this. Now, this is an old study, but it's important because it's been very influential, which is why I choose this one. The author of the study is Didier Petit, and he still does work in Geneva Hospital in Switzerland. And yes, I thought I missed a slide out there. Sorry. So the University Hospital in Switzerland wanted to implement a hand hygiene campaign. So what they did was they had a complex bundle. They introduced alcohol hand rub. They introduced posters at a time when people didn't use alcohol hand rub very much, when it was very novel then. And they audited hand hygiene. They gave people performance feedback, and they got support from the management of the hospital for what they were doing, remembering that what they were doing at the time was very novel. And they measured hand hygiene frequency and overall rates of healthcare-associated infection, and MRSA rates they measured also, MRSA being the infection that people were most concerned about at the time. And they collected data by looking at hand hygiene. They did a manual audit. So they wrote a study protocol. They collected baseline data for all their outcome measures, hand hygiene and the infection rates. They put their campaign in place, and they followed up with data collection at 6 months, 12 months, and they went on ad infinitum, 18 months, 2 years, and what have you. And the results for the period of data collection, which was 4 years, they did 834 hours of audit. So that's a lot of hours of audit. And they looked at over 20,000 hand hygiene opportunities. And they found that hand hygiene adherence increased for nurses and increased for unqualified healthcare workers, but not for doctors, as you might expect. Hand hygiene adherence increased overall for the sample from nearly 48% to nearly 67%, so 20% increase, which is considerable. And the overall rates of healthcare-associated infections declined considerably from practically 17% to 10%, and MRSA rates declined as well. That's not quite so dramatic because they were never very high in the first place, but there still is a decrease there. So if we apply the critical appraisal skills program, what are the study findings? Well, we've just had those. Do you believe in the findings? And are they going to be helpful to where you work? Now, usually we would have about 10 minutes group work there, but just for 2 minutes yourself, think, look at what they did, look at the study protocol. They had baseline data, they put their campaign in place, they had follow-up data. What kind of study was that? Do you think that that's very good evidence? And would you implement, do you think those findings apply everywhere? Just for 2 minutes, think to yourself. What kind of study was this? Was it a trial? Was it a randomized controlled trial? Was it interrupted time series study? It certainly wasn't a case series study. It wasn't a cohort study. But do you believe in the findings? So there are some hints here. Was it high quality evidence? Was there a control group? Was that sample randomly obtained? Was there evidence of bias? Do you think the hospital in Geneva represents hospitals more generally? Have you ever been to Switzerland? Is it a poor country or is it a rich one? Is it typical of everywhere? So what kind of study design was it? Well, it was an uncontrolled before and after study design, wasn't it? It was clearly pre and post test. Everybody was acting as their own control. Everybody got the intervention. So it wasn't a trial. It was an uncontrolled before and after study. There was no randomization there. Everybody took part. So the group that got the intervention acted as its own control. So it's not very high up the hierarchy of evidence, and it's in a highly specific setting because Geneva is not the same really as everywhere. Switzerland, if you hadn't realized it, is a very, very, very wealthy country indeed. It has a very good healthcare system. And I would think that probably Geneva is a very wealthy part. Well, Geneva is quite a wealthy part of Switzerland. And I would think that the University Hospital in Geneva is probably a flagship hospital in Geneva. So although the study is low down the hierarchy of evidence, we know that things in Geneva are very, very good quality. If you ever go for a weekend or a holiday in Geneva, as you walk through the airport, as you go back through the airport, the duty-free shops are all shops where very wealthy people would do their shopping. Geneva is a very rich place. Would the findings that you got in Geneva apply to the hospital where you worked? I don't think they would apply to the University Hospital in Cardiff when I was there a few years ago, and the sort of hospital that was. When I was in Geneva at a conference a few years ago, it was borne home to me how different Geneva is from a lot of the rest of the world. After the conference, Didier Petit, who was at the conference, who did this study, said, let's go to my house and we'll have the evening there. We'll have a party there. So we got there and we had a nice time. We had a nice time with some wine and some cheese and all sorts of other things. And at the other end of the evening, we said, Didier, we've got to get back to our hotels now. How should we get back to our hotels? Do you think we'd better call a taxi? And he said, no, there's no need at all. You can catch the bus. So we said, well, where should we catch the bus and what time and everything? And he said, oh, that's very easy. All you need to do is stand outside the front gate and at 10:20, the bus will come. So we said, well, suppose it doesn't come. And he said, don't be ridiculous. Of course the bus is going to come. The bus always comes. So we said, when the bus comes, what are we going to do about money? Because we haven't got any local currency. So he said, all people in Geneva, all tourists in Geneva travel free. All tourists never have to pay in Geneva. So we said, but how will the bus driver know that we're tourists? And Didier said, oh, of course the bus driver will know you're tourists. Of course the bus is going to come. All you need to do is just stand there and the bus will come and it will drop you off at the tram stop in the middle of the city. And then in 5 minutes' time, you can pick up a local bus and that'll take you to your hotel. And you won't have to pay on that. It'll be fine. So we didn't think that any of this would work. Can you imagine it working in London or Manchester or Liverpool or anywhere really? But we stood by the gate and at 10:20, the bus did come. And the bus driver waved us on, and we waited for 5 minutes in the middle of the city. And then there was the local bus, and 5 minutes later we were outside our hotels. And when we were waiting in the middle of the city, a friend that I've known for many years said, "Oh, Dinah, if we were waiting in the city, in the middle that we didn't know, in the middle of the night in a strange place, I'd be frightened, but I don't feel especially scared. I don't feel particularly nervous here." And I didn't either. Now, I'm not trying to suggest that there aren't places of Geneva that would be dodgy. There are in all cities. But, I mean, can you imagine where you live, wherever it is, a bus coming on time and being able to get on it and not prove who you were and to be taken quite safely to where you were going? I mean, it's unimaginable, isn't it? It's like another world. So I think that we can say about Geneva that it is not like other places, and that findings that were accrued, that were gathered in a hospital in Geneva, probably don't apply to anywhere else in the world. So what we can say about this study is that the results are likely to be very, very highly biased because of the place it was done in, and because the study design isn't particularly sophisticated. It was before and after study. So what can we say that's good about this study? There's lots that's good about this study, which is very famous. It's highly original. There's an enormous amount of imagination was required to conceive it, because although we use alcohol hand rub every day now, there was a time when we didn't, and somebody had to think of it first, and it was at this hospital that somebody did. The study was very skillfully executed. Except for doctors, everybody was persuaded that hand hygiene was important at a time when people were much more skeptical than today. The study is very well written up indeed, with an excellent critique of the method. It was written up in the Lancet, and the people who wrote the study never pretended that it was a trial, and they critique it very well themselves. So they never try to pretend to you that they did something that was a lot cleverer than what they really did in terms of study design. It's worth getting the study out and reading it. The findings of the study were very well disseminated in academic journals and with policymakers. And this study actually underpins the hand hygiene that we have in this country and throughout much of the rest of the world. There's an element of luck there. Geneva is the home of the World Health Organization, and the people who work in the Geneva University hospitals have very close contact and work very closely with the World Health Organization. So there is some serendipity there. But this study has had enormous impact. It has been cited many times. It underpins the whole World Health Organization guidelines for hand hygiene, the ones that were published in 2009 and that have been updated since. It has influenced policy and practice globally. It has influenced the places where you work. So this is a study that really, 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 really is important. Now it's almost time to finish, but I think we can have a few final words here. What matters when we implement and update a local infection prevention control policy and guidance is to use evidence where it exists and to use common sense where it doesn't. And nurses are very sensible people, so you've got plenty of common sense. We need to keep a sense of proportion. Some things are never going to be underpinned by the best possible evidence for all sorts of practical reasons. But we can still make sure that people do bare below the elbows because pragmatically it makes sense. Feasibility and practicality are very important. And these days, I'm afraid cost is as well. And you can't forget economics these days. And there are things we might like to do, but there are things that we can't do because of money. But we don't have to waste time doing silly things and dangerous things the way that we did years ago, as I've described to you earlier today. Organizational need is important. In one of the groups, clearly people came from very different organizations and they had a good discussion about that, and that's important. And there's local need varies a lot within organizations as well. What does in one part of an organization doesn't do throughout the organization. So thank you very much indeed for your company these past few days. And I hope that you go out and you prevent all the infections that you can. Don't forget the parachute study though. And don't forget the message that it carries, entertaining though it is. And I have to say that it's been very enjoyable to be with you. And we've had some of the best group discussion that we've ever had in the course so far. And I think we've had a pretty good time, really. Thank you very much.
That's Brilliant. Thank you. Thank you, Dinah. While we're sort of thanking Dinah and asking if there's any final questions, I'm going to ask Crystal if she can pop the link in the chat, please, to the evaluation form so that for the last 2 days, so that you guys can start filling that in for us. That would be absolutely great. And thank you, Dinah. Lovely lecture as always. And we've probably got time for 1 or 2 questions if there are any more for Dinah. But if while you're doing the questions, you could carry on filling in your evaluation forms, that'd be great. Thank you. Faith.
Hello. Thank you, Diana, for the training. I just have a little question. In regards to IPC and hand washing, like we've discussed, the readmission of patients, what do you think? What time frame would you think it's applicable for a patient to be readmitted into a unit that once had a case of MRSA or CAPS?
That ever had, you mean, or recently had, or
a ward or a unit that have had a patient let's say the patient was discharged a day ago or yesterday. Is it right for a patient to be readmitted into the same unit after a supposedly deep clean?
So it depends where they're going to be placed in that unit.
There's a lot of things there, and there's a lot of assumptions there. Was the patient infectious? Is the patient still infectious? Where are we going to put them? And pragmatically, if we don't do it, what else are we going to do with the patient?
Yeah, that's what.
Where else are we going to put them?
For example, a ward that is a bay of 4 patients, and in the bay we had a patient that's had MRSA before, and so the ward was closed by infection team, and after the patient was discharged, the people domestic came and did a deep clean. Is it right for the patient to be another patient that doesn't have any infectious agents to be admitted into that ward that harbored MRSA in less than 24 hours?
So what are you asking? Are you asking whether it's safe or?
Yes. Is it safe for a patient that don't have any infectious agents to be admitted in a ward that once harbored MRSA less than 24 hours ago?
It all depends on how good that cleaning was. Now, there is a gentleman called John Otter, who at the moment works at St Thomas's Hospital, where he's in charge of infection prevention and control. And he does a lot of research. And John Otter does a lot of research about environmental cleaning. And some of the work that he's done shows that the quality of environmental cleaning is very, very important. And that if somebody is admitted to a patient that's previously been occupied by a patient who's had an infection, their chance of becoming infected is higher than if the room or the ward had not been previously occupied by an infected patient. But much depends on how well that terminal cleaning was. And just as there's been a lot of technology about waterless wards, there's a lot of technology development around terminal cleaning and a lot of research around contactless cleaning and cleaning with things like hydrogen peroxide machines, which are supposedly much, much more efficient than manual cleaning would be. Now, you have special technology and people trained to use it. So again, we need far more trials in the way of how good this terminal cleaning is, but almost certainly automated terminal cleaning would be safer and better than manual cleaning.
Could you please help me with the information of the John Otter so I can get some of his work and research on that?
John Otter, otter is spelled as in the animal. So if you want to get the research, do you know Google Scholar?
Yes, I do.
If you go into Google Scholar, Otter is a fairly unusual name. If you put Otter in there and then you put environmental cleaning, that should bring up the references. But I do have them on my computer at home. I can send them to Tina or Chris and get them to be forwarded.
Sorry, can I just jump in before we go any further? Crystal, the people are saying the evaluation form saying it will only be available after day 4.
Oh, yeah, I'm just having a look now. Sorry, guys.
Thank you. Back to you, Dinah.
Okay. What I'll do is I'll sort out some references and I'll send them to whoever it is best to send them to, and then they can send them on. But I might not get round to doing it today because I have to go out this afternoon straight from here.
Dinah, if you send them to me, I'll upload them onto the discussion group.
John Otter has done quite a lot of research, but other people have done research as well. So I've got the papers. I know where they are. I can pick them up and send them.
Thank you so much.
And they will be in journals that the RCN takes as well. They'll be in the Journal of Hospital Infection, and I think also the Journal of Infection and Hospital Epidemiology, which the RCN does take. I don't know if Coventry does, but the RCN library does. So look for them in the RCN library.